Hello, good morning. Are we audible? Hello.
Hi, you're audible?
Yes, ma'am.
Thank you, sir. We'll take a quick roll call before starting the session.
Is Dr. M. Pushpa Kumari present? Yeah, okay. Dr. Sushma A.
Yes, ma'am.
Dr. Kavita V. Okay, I don't think she's. Dr. Shabina Akbar.
Yeah, present.
Dr. R. Naveta. Dr. R. Naveta.
No.
Okay. Dr. Divya NR. Dr. Divya.
Yes, I'm present.
And Dr. Manasa Jaskar.
Present.
Uh, is Dr. Kavita V on call?
Thank you. You want to attend? You want to listen?
Is Dr. Niveta on call?
Present.
Dr. Jayashree and Dr. Naveen, one of the participant is not on call. Should we start the session or would you like to wait for them?
You can start off, Ma. You can start off. Then they'll join later on.
Okay, thank you, ma'am. Good afternoon.
Yes, just sorry. I think Niveta just now replied. I think she's on, I think.
Yeah. We've
Yes, sir. Dr. Kavita V hasn't joined the call.
Ma'am, we both are there. We both in same place, ma'am.
Okay, thank you.
okay. All right.
Okay.
Okay. Good morning, everyone. Welcome to the 32nd State Level Annual Conference for the Association of Community Health, hosted by RMC.
The theme for this year is redefining public health, COVID and beyond.
So today we will begin with our session, which is the PG poster presentation.
Okay, let us take this opportunity to introduce the esteemed judges for the day. Dr. Jayashree, Professor and Head, BJS Bangalore. Dr. Naveen R, Associate Professor from St. John's Medical College, Bangalore.
Thank you for dedicating your precious time to judge this session.
And just for your information, sorry, once again, just for your information, Dr. Jayashree and me are classmates in PG days.
Dr. Naveen, what a coincidence. That's nice. It'll be nice working with you.
Yeah, thank you.
Yeah.
Today's session will be moderated by myself, Bhumika, from 5th term.
And myself, Prakriti, from 5th term, MSRMC.
And Dr. Anantram.
Okay, we will go through the instructions for today. Okay, please make sure you have an uninterrupted internet connection. Make sure that you have entered this WebEx meeting under your own name, and make sure your camera and microphone are functioning properly. Make sure you are seated in an isolated and closed space with proper lighting. Mute your microphones when you are not speaking. Make sure you can minimize distractions from the background and avoid echo. Stay seated and stay present, and please stick to the given time frame. Your presentations will be stopped if you are exceeding the given time.
The participants will be given 5 minutes each to present their poster and 2 minutes for questions by the judges. Let's start the session with the first participant, Dr. M. Pushpakumari, registration ID RMC KSCH 0278.
Would you like to present the screen or should we?
Dr. M. Pushpakumari. Are you able to share your presentation?
Able to share my screen.
Ma'am, can you try again now?
Yeah, we have made you the presenter. Just try once again if you could share your screen. Yeah, we have it.
Ma'am, can you try sharing it now? She's with.
Yeah.
Dr. Pushpakumari, if you are not able to share, then we have your PPT slide, your poster. We can. Would that be okay?
Sir, I'm not
She said,
able to share.
yeah.
Thank you. Ma'am, you may begin presenting. Dr. Pushpa Kumari, you may begin presenting now. Hello, ma'am. Ma'am, your poster is not seen. Do you want us to share it?
Able to share, please. Hello.
Yes, ma'am.
Dr. Pushpakumari, it's apparent that your network is not, is poor. So it will be difficult for you to share and then present with the same bandwidth. So we'll share the screen. We'll present your slide. If you can present for 4 minutes, that would be helpful. So we'll present your slide. Full screen. Time starts now.
Ma'am, you may begin presenting now.
The screen is not visible.
Not visible.
It is. Just a minute, ma'am. Ma'am, is it
Good morning
visible
to
now?
all of you. Ah, good. My poster presentation is about the topic a study on prevalence of internet addiction among students of Mina. Internet users across the country, and this figure will grow over up to 974 million users by 2025. So we have to reduce that number in order to not be addicted. So internet has become an essential tool in day-to-day life, and now is a two-edged sword, having its own pros and cons. And my objectives in my study is to estimate the prevalence of internet addiction. My study design is cross-sectional study. My study is 1.96 and prevalence is 90 and
Dr. Pushpa Kumari, you're not audible. Yeah. You're audible now.
Sample size is 121, and my sampling method I have used in this study is simple random sampling. Study population I have took about second and third year undergraduate students from Meenakshi Medical College and Research Institute, and the tool I have used is Young's internet addiction test, and the method of data collection I have made an online survey via the Google Forms, and the results is the prevalence of my internet addiction study is. Under this, I have divided it as no addiction, mild addiction, moderate addiction, and severe addiction. Normal addiction, normal people under my study is for about 22.4%, and mild addiction is 61.9%, and the moderate addiction in my study is 15.7%, and there is no candidates of severe addiction. This I have made one and bar diagram by gender-wise prevalence. In this, I have made males and females as classified as no addiction and mild addiction and moderate addiction. And my strength and limitations of this study is I have used a validated scale, which is Young's internet addiction test. And under this pandemic situation, I have made this study. And the limitations of my study is selection of only one college and the online survey. And the conclusion of my study is the prevalence of internet addiction among males they are 85.6% and females as 66.6%. And the recommendations of these are the students has to know about the usage and over usage of internet, and the awareness should be given to them about the same. And these are my references, and this is my
Dr. Naveen, you want to start? You want to ask something?
Go ahead, Jayashree. It'll be your first turn and mine will be second turn. Let's keep that going.
Okay. Dr. Pushpa, congratulations for your presentation and your poster. It's quite a neat poster. In the introduction, you haven't mentioned anything about medical students. How are they different from the general population? What are you given in general population data?
okay, ma'am. Okay. The statistics is of what general population they have given, ma'am.
Okay. Besides the gender, have you used any other variables? Have you studied any other variables?
No, ma'am. Actually, this is my first study after my joining to post graduation. So I have
Okay, fine. I'm done, Dr. Naveen. Okay, now.
Okay. Dr. Pushpa, the question to you is, do you try to look at what were the reasons they were using internet for?
yes, sir.
Did
Actually,
you try looking at, go ahead.
under my Young's addiction, there are few questions about why they are using for long time or deep disturbances are there.
No,
Under
I'm
that,
trying
I
to,
have studied.
no, Dr. Pushpa, my question is, did you try looking at what were the reasons they were using internet for? Because with the COVID situation, all of us are taking online classes, right? That's
Okay.
also use of an internet. Was that the reason why the internet use was on the higher side?
No, sir. Beyond that study, beyond that classes, they are using internet for other purposes also, sir.
Okay, have you captured the data?
No, sir. I will take in my studies, sir.
Thank you, Dr. Pushpa, and then best wishes.
Okay, thank you,
You're
sir. Thank you.
done now. Okay.
Host, you can go ahead with the second presenter.
Yes, ma'am. Thank you. Thank you, Dr. Pushpa Kumari. We'll move on to the next participant, Dr. Sushma A. Registration ID RMC KSCH 0288. Ma'am, are you there? Dr. Sushma? Hello, Dr. Sushma? Ma'am, are we audible?
Yeah,
yeah.
Bhumika and Prakruti, you're audible.
Okay.
What I suggest is, if you want, you can go to the third presenter, and probably if Sushma comes back, we can restart rather than wasting time.
Yes, sir. Thank you. Dr. Kavita V. Registration ID RMC KCH 0294.
Yes. Yes, ma'am.
Yeah. You'll share your presentation now.
Yes, ma'am.
அவங்க பிளாக் பண்ணிருக்காங்க. அவங்க ஷேர் கொடுத்ததுக்கு அப்புறம் தான் நம்மளால ஷேர் பண்ண முடியும்.
Dr. Kavita, is it
Yes,
visible?
ma'am. Can I? Visible, ma'am.
Yes.
Can you hear me, ma'am?
Sorry?
Can you
Yes.
hear me, ma'am?
Yes, ma'am. Yes.
Okay.
You may start
Okay, ma'am.
presenting.
Okay, ma'am. Good morning, sir and ma'am. I am Dr. Kavita. My guide is Dr. Balaji, Tagore Medical Professor and HOD, Tagore Medical College. I am going to present this poster today. That is topic is impact of COVID-19 lockdown on glycemic control in patient with diabetes. My introduction. Diabetes is a chronic metabolic disease characterized by elevated levels of blood glucose, which leads over time to serious damage to multiple organs. Adoption of good lifestyle modification, which includes balanced diet, exercise, proper sleep, and psychological well-being with proper medication under medical guidance, are the pillars for good glycemic control. All these pillars may be shaken in the lockdown period. My objectives: to study the impact of COVID-19 lockdown on glycemic control in patients with diabetes. Materials and methods: study design is cross-section study, sample size is 25, the convenience sampling. Study duration is November 1st week to 2020. After the immediate lockdown period, I took study population is type 2 diabetes patient who had attended OPD, and the good glycemic control in the fast time, and also no chronic complications. Study setting is urban health center Chromepay. Study tool is blood drawn from the type 2 diabetic patients to measure the fasting blood sugar and postprandial blood sugar and also random blood sugar measured by the automatic biochemical analyzer. Method of data collection with written informed consent data collected from the patient. My research is the study involved 25 type 2 diabetic patients, 14 men, 56%, and 11 women, 44%, with a mean age of 55.56 plus or minus
Dr.
5.
Kavita, you're not audible.
Hello, ma'am. Now audible, ma'am?
Yes, ma'am, you're
Now-
audible. You're audible.
Okay. Can I start results or materials and methods, ma'am? Hello, ma'am.
Hello, hello.
Can
Dr. Kavita, you're not audible.
now, ma'am?
Ma'am, actually, she is audible. Maybe there's a problem.
Dr. Jayashree, Dr. Kavita is audible to us.
Okay, ma'am. Can I start with results or materials? Where I start, ma'am?
Dr. Jayashree,
Bhumika and Prakriti, I think you'll have to check with Dr. Jayashree if she's having a problem.
Yes, sir. Are you able to hear Dr. Kavita, sir?
Okay,
I'm
ma'am.
able to hear.
Okay, ma'am. Sir, can I start? Can
Just
I?
a second, Dr. Kavita. Dr.
Kavita, just
Jayashree,
wait.
Okay, okay, sir.
Dr. Jayashree, stop sharing. Dr. Jayashree,
Yes, only now. We can hear you now, ma.
yes, ma'am.
Yes, ma'am.
Thank you. I'll share the presentation again. Ma'am, you may resume your presentation.
Dr. Kavita.
Yes, ma'am. Can I start from? Can you hear me, ma'am?
Dr. Kavita, you're audible. Can you please start from the result section?
Okay, ma'am. Okay, sir. My study involved 25 type 2 diabetic patients, 14 men involved and 11 women involved with a mean age of 55.56 plus or minus 5 years. That is the pie chart involved that the glycemic control after lockdown, that 12% only loss of that good glycemic control, 88% having the loss of glycemic control. And also that have the table that is the I use that pad t-test for statistical analysis, that before and after lockdown we have the mean and plus or minus standard deviation. That is the p-value is very significant, that fasting blood sugar is less than 0.01 is having the significant value, and also postprandial blood sugar also significant significant value. And the random blood sugar also, that before and after calculation, that is the p-value is very significant. That is the bar chart. We having the before and after mean plus or minus mean value of blood glucose. That is the so much that is very important. That light blue is the before lockdown. That is the dark blue is the after lockdown. This is also very significant. So that my study involving very significant value in the PAD T test. This involving that also the strength and limitation, that immediate awareness given immediate awareness and education given to the patient after glycemic control. That limitation is the further investigation to rule out the complication not included. That conclusion, this study showed that overall glycemic control got deranged during the lockdown period. Recommendation, this study was a small sample size and shorter duration. Further studies, the larger sample and duration are needed. This is my reference, and acknowledge my HOD and Department of Community Medicine and staffs and supporting to conduct these studies. Thank you, sir. Thank you, ma'am.
Thank you, Dr. Kavita. Dr. Naveen, you take over.
Dr. Kavita, you have only taken sample size of 25 people and then you're saying it is significant.
Yes,
are you happy with that?
But is the immediate, I took the time period is that is after immediate of opening the lockdown, I measured that first week, sir. That is the that awareness of the glycemic control we know about, sir.
No, Kavita, my question is, are you happy with your sample size of 25?
No, sir.
Then, and what test did you use to say it is significant or not significant?
It is we use the t-test statistical analysis. They use the value of my studies values. I put that this significance before that lockdown period. They having the glycemic control good, sir.
No, Dr. Kavita, wait, Dr. Kavita. My question is very clear. What statistical test did you do to say it is significant or not significant?
PAD t-test, sir. Less than 30 samples, less than 30 small sample size. So we have to analyze that using the t-test, sir.
Okay, thank you.
Thank you, sir.
Go ahead, Jayashree.
Yeah, Dr. Kavita.
Yes, ma'am.
When you use the word impact, that has a lot of implication. How can you attribute this, whatever said, despite the poor sample size and all that, how do you attribute this poor glycemic control to lockdown only?
This people that I took the study people for study population is a mean age group 55 years that have the lockdown time. They have to inside the home. So according to that value that not proper
these factors what you have mentioned in the introduction, did you go into those factors? Did you find out did they have difficulty in getting the medication or sleep disturbance? Did you assess their psychological well-being and their diet, lack of exercise? Was there a difference in exercise regime?
No, ma'am, I didn't took that this all, ma'am. That future studies, I took that all the factors.
How did you get to know their earlier glycemic control based on records? Is it?
Yes, ma'am. Yes, ma'am. Records before.
Okay. How many days prior? How many days prior did you look into?
6 months. 6 months, ma'am. 6 months, ma'am.
6 months. And you have taken only FBS and PPBS. You have not even taken glycosylated hemoglobin, right? What is the definition of glycemic control? Good glycemic control?
That is good glycemic control means that is the less than 110 means that fasting maximum fasting is blood glucose less than 110, ma'am. That is the host.
Thank you, Dr. Kavita. Thank you.
Okay, ma'am. Okay.
You can move ahead to next study. Yeah.
Thank you, judges. Thank you, Dr. Kavita.
Okay.
Is Dr. Sushma ready to present? No. Oh, yeah. Dr. Sushma?
Go ahead with next presenter. Sushma is not a
Yes, ma'am. We'll move on to the next participant, Dr. Shabina.
Yeah, I'm ready.
Oh, yeah. So, Dr. Shabina will share your presentation now. Let me present it. Okay. That's fine. Ma'am, is it visible?
Yes.
Yeah.
You
So
may
shall I
start.
start? Am I audible?
Yeah.
Okay, I'm Dr. Shabina, doing second year PG in JSS Medical College, Mysuru. Uh, Today I'm going to present a poster on a comparative study done of malnutrition and anemia among the middle adolescents children of urban and rural high school students of Mysuru district, Karnataka. So going to the introduction, one of the basic requirement to grow and to sustain life is nutrition. Growth will be affected if there is deficiency in the nutrition intake, either in quantity or in quality. So malnutrition happens to be one of the largest public health problems in the developing countries among school-going children. And nutritional anthropometry has a significant role in the assessment of nutritional status among the school children. So going to the objectives, the main objective was to estimate the prevalence of anemia and malnutrition among the high school children of urban and rural areas. And the second one was to assess the association between malnutrition and anemia with the social demographic features in the same children. So going to the materials and methods, the study design was a cross-sectional study, and the study sample was, the sample size was around 400 students among the selected high school children of rural and urban areas. The study population and settings was JSS High School, children of rural and urban areas of Mysuru. The method of data collection was socio-demographic data were collected using a semi-structured questionnaire, and the anthropometric measurement was taken and entered in the Excel sheet and analyzed using SPSS version 24.
Dr. Shabina is not audible.
Dr. Shabina?
Yeah. Am I not audible?
Yeah, now you're
Hello?
audible. Start from results. Yeah.
Yeah. Shall I start, ma'am?
Yeah, from result section. Yeah.
Yeah, okay. So starting from the result, the first graph is showing the distribution of presence or absence of pallor in urban and rural high school students. What it shows is the rural girl children had higher prevalence than the urban. And when you go to the second graph, it is showing the distribution of malnutrition in this between the urban and rural high school. There was a peculiar finding that the urban urban showed more malnutrition than the rural population. So we went to do further the association between the socio-demographic variables and anemia among these children, what we found out was the rural girls, I mean, the graph has disappeared. The rural girls had higher anemia, and which was statistically significant. This was done using a chi-square test. And we did a next association between the socio-demographic factors and the malnutrition, which showed that the urban boys had uh, thinning and severe thinning when compared to girls. And when obesity was looked into, it was more in females, and that too in rural. So, and that too in urban, sorry. So what we found out was the conclusion of the studies was anemia is more prevalent among the rural girls, and severe thinning was more prevalent in urban boys. So the limitation of the study could not be generalized as to the overall population. And what recommendation we suggest is we have to do a periodic screening and give a good health education to the teachers as well as the family members. And these are my reference, and I thank for the presentation. I mean, hello.
Yes, Dr. Shabina. Okay,
Yeah,
now
ma'am.
what do you mean by mid-adolescent?
Like I just took the high school population from 15 to 19 years, ma'am. The with
Is that mid-adolescence? How do you define adolescence?
8th, 9th, and 10th standard high school students.
How do you define adolescence?
Like adolescence is from 10 to 19 years. It is divided into early, mid, and late. Early is from 0 to 15, then 15 to 0 to 14, 14 to 17, and
Now,
17.
when you're done on high school students, you could have put the title as high school students only. You could have
Okay.
Other age group also in that. Okay.
Okay.
Dr. Naveen.
Okay. Shabina, thing is, you have identified anemia by PALA.
Yes, sir.
How significant is it, or what's its applicability?
So it was just a one-day study that like we usually go for a school health in the schools around JSS. Like that was around, it is in our curriculum that we go and have a school health visit to all the schools over there. So we just had one day time. So what we could do is we just did the presence and absence of pallor.
What
We
is the
have
sensitivity of pallor? That's what sir is asking. How sensitive is detecting pallor to detect anemia? Do you have any data on that?
No, ma'am.
Okay. Well, the second question probably, Shabina, is if you are given an opportunity next year to do a better study, what would you like to assess?
I'll go for a hemoglobin estimation as well.
But you're saying that you get only one day to do. Do you want to look at something else among school children?
Like if I get a permit, like what I found out mainly in the study is the urban were most affected and rural was better. And when I went into further studies, I found that all the urban students were coming from a hostel, and the rural people students were coming from a home. So food supply. So this can be overcome.
Okay. Thank you, Shabina.
Yeah. Thank you, everyone.
Thank you, judges. Thank you, Dr. Shabin.
Yeah.
We'll move on to the next participant, Dr. R. Niveta, registration ID RMC-KSCH 0313. We'll
Okay, ma'am. Good morning, everybody.
Morning.
Can I start my presentation, ma'am?
Yes, ma. This is.
I am Dr. R. Niveta. I am doing my first year MD Community Medicine in Tagore Medical College in Chennai. My guide is Dr. A. Balaji and Dr. A. R. Radhakrishnan. My topic for my e-poster presentation is anxiety and depression among doctors during COVID-19 pandemic. Introduction is in earlier December 2019, an outbreak of COVID-19 caused by a novel severe acute respiratory syndrome coronavirus 2 occurred in Wuhan City, China. Due to it, healthcare workers are at a significant risk of psychiatric morbidity. During COVID-19 pandemic, especially among doctors who stands in front of this crisis. Objective of my study is to assess the level of anxiety and depression among doctors during COVID-19 pandemic to determine the factors influencing anxiety and depression among the study participants. Materials and methodology of my study is a cross-sectional study conducted among the physicians working in COVID care center in Chennai and excluded the doctors with previous history of psychiatric illness. And my study period is from September 2020 to October 2020 and sample size is 100 and convenient sampling. Study tool is Hamilton Anxiety and Depression Rating Scale and method of data collection is through online Google form and the data entry was done in Microsoft Excel 2010 and statistic analyzation was done by SPSS software 20 and statistic measure done was mean, proportion, percentage and chi-square. Result, figure 1, the bar diagram showing the percentage of anxiety among doctors. Among 100 doctors, 24 have mild anxiety symptoms and 16 having moderate anxiety symptoms and 8 has severe anxiety symptoms. Totally 48% have anxiety symptoms and second bar diagram showing the percentage of depression among doctors. In this, out of 100 doctors, 42% having depression. In this, 27 have mild depression, 9 has moderate depression, and 6 has severe depression symptoms. Limitation and recommendation of my study: the sample size was small, and follow-up of the doctors was difficult since data was collected through online. In future studies, large number of doctors should be included and contact details should be collected for follow-up. Conclusion of my study is the study highlighted the doctors who are treating the COVID-19 affected patients suffering from psychiatric morbidities. These are my references. My acknowledges is to my Department of Community Medicine in Tagore Medical College and my HOD, Dr. Balaji. Thank you.
Dr. Naveen.
Thank you, Dr. Niveta. The question is, how have you addressed your second objective?
My association of this, my study based upon the education qualification, MBBS students have high anxiety and depression compared to PGs and PG and diploma candidate, ma'am. I didn't mention in my poster during doing it, sir.
Okay, the only factor you looked at is whether they are senior residents or consultants. That's the only thing, is it? Did you look at anything else?
Yes.
What else?
Education qualification and their salary range also I asked this, sir, but it does not have any significance.
Okay, thank you. Jayashree, go ahead, ma'am.
Yeah.
Thank you,
Dr. Niveta. Yeah, one is your exclusion criteria. You said not known case of psychiatric illness. What is the hidden anxiety and depression? What is the normal prevalence among the doctor population? I'm talking about the hidden morbidity. Okay, so you don't know the baseline. So we are not aware of the baseline values, isn't it? For it to be compared with those with working in COVID. And second thing is, yeah, why did you mention in your further studies, limitations and recommendations, further studies, why follow up, contact details and follow up? Why do you want to do follow up?
In severe depressed doctors, we can have any, we can follow up and we can educate them and can have any treatment to them, ma'am. Give treatment or any
How will it
awareness
be
to
a
that.
recommendation? How will it be a recommendation of your study? You have not done any follow-up, no? To see if
Yes,
there will
ma'am.
be any positive outcomes? Okay, fine. Thank you. Thank you.
Thank you, ma'am.
Thank you, Dr. Niveta.
Thank
Next
you, ma'am.
participant, we'll have the next participant now, Dr. Divya NR, registration ID RMC KSCH 0319.
Yes, I'm here. I want to share my screen.
Yes,
Yeah,
ma'am.
we're making you the presenter.
Can you share now?
Yes. Oh, good morning, all. Am I audible?
Yes, ma'am.
I'm Dr. Divya NR, postgraduate student, Department of Community Medicine, MS Ramaya Medical College, Bangalore. Today I'm presenting a poster on quality of life among those with chronic obstructive pulmonary disease, a cross-sectional study. The introduction and the need for starting the study is COPD is one of the third leading cause of mortality and morbidity. COPD has a major impact on health status by affecting the daily activities of life, and if it is not managed properly, it can contribute to a significant proportion of people who may suffer increased disability and reduce quality of life. So the care of COPD patients can only be optimized if there is a reliable, standardized measure of the overall effect of the disease on each patient's health. Objective of my study is to assess the quality of life among those with COPD in Devanali town, Karnataka. Coming to details and methods, my study is a cross-sectional study. It was done among confirmed COPD patients in Devanali town, Karnataka. The sample size was 46. It was selected as a part of larger study. In my larger study, I had done sampling. I had employed simple random sampling and probability proportionate to sample size to come to the sample size. And I have used COPD assessment test questionnaire as the tool here. According to that, based on the scores, more than 30 had very high, those who scored more than 30 had very high impact on the quality of life, more than 20 had high impact, 10 to 20 had medium impact, and less than 10 had low impact on quality of life. In the statistical analysis, to assess the quantitative variables, we've used median and interquartile range. And in order to find out the association between the risk factor and the quality of life, chi-square test was employed. And to find out the independent predictors, logistic regression test was employed. Coming to the results, so among 46 COPD, confirmed COPD patients, 28, that is 60.9% were males and the rest were females. The median CAT score was 19 and the range was 24.6 to 13.4. And this median CAT score was in the medium impact of quality of life. And it was noted that 6.5%, 36.9%, 43.5%, and 13% had low, medium, high, and very high impact on quality of life, respectively. Coming to the factors associated with the quality of life in COPD, where the tool used was CAT questionnaire, there was a significant association with quality of life with gender, smoking, and dyspnea in univariate analysis. In multivariate analysis, smoking and dyspnea had a significant association with the quality of the life. And strengths of my study is I've used a standard validated disease-specific tool to assess the quality of life. And the limitation is this is the cross-sectional study, so only the association could be established and the causal inference could not be established. The conclusion is this study showed that the COPD had a very high impact on the quality of life, indicating the need for improvement by additional pharmacological treatments and pulmonary rehabilitation. And the recommendation is assessment of quality of life among COPD patients is required, which can be used in clinical practice along with appropriate treatment plan. So, in public health perspective, it is important. It is important to add life to years, not just years to life. That's why quality of life assessment is very important. And this is my reference. And I would like to acknowledge my guides and Department of Community Medicine and all the staff and the study subjects and the Taluk Health Officer Devnali, who has given me an opportunity to conduct the study. Thank you.
Dr. Naveen.
Okay, thank you. Good study, Divya, and then good statistics you have used. In your sample size, you said 46 people, and everybody with COPD were included in your study. Am I correct?
Yes, sir.
And how did you know there were only 46 people in Devnalli?
So, as a larger study, I had done the prevalence of COPD among 1,067 study subjects. I had performed spirometry and confirmed 46 COPD patients, and then among them, the quality of life was seen, sir.
Okay, but how do you know there are only 1,100 people with COPD in Devnalli?
Sir, 1,167 was not the COPD patients. It was my sample size on which I saw the prevalence of COPD, sir.
Yeah, so since you have gone into such a detail, it would have been good if you are very clear, not to say people in Devnalli, it is people among your larger sample size, right?
Okay,
it's not everybody in the Devnalli town. Now, since you have gone into such intricacies and done a good study, we just wanted to give you a comment on that. Otherwise, good presentation and all the best, Divya.
Thank you, sir.
Yeah, yes, Divya, I have only one question with regard to your conclusion. You have mentioned in your multivariate analysis, you found smoking and dyspnea as the associated factors, isn't it? So you have not mentioned in your recommendation lifestyle modification in terms of cessation of smoking habits. And then, of course, you have mentioned about pharmacological treatment and pulmonary rehabilitation. That is for dyspnea, isn't it?
Yes,
So
ma'am.
you are recommending that those drugs. So you should have probably included that also. Because you already told smoking is one of the factors. Otherwise, good presentation. Congrats. Thank you.
Thank you all. Thank you.
Thank you, Dr. Divya. Thank you, judges.
Am I audible? This is Dr. Sushma.
Yes, ma'am.
Yes, Sushma.
Okay, I'd like to present now.
Yes, ma'am. 1 minute. Dr. Divya, can you stop sharing your screen?
Yes, yes.
Dr. Sushma, can you share your screen now?
Is my PPT visible?
No, ma'am.
Share. Do the share.
Dr. Sushma, will you present after
Yes,
the next participant?
1 second, 1 second. Okay, I'll present next.
Thank you. Next, we have Dr. Manasa Devakar, registration ID RMC KSCH 0321.
Hello.
Yes, ma'am.
I would
We'll
request
take
to
you the
host.
presenter. Ma'am, are you able to present now? Share your screen now.
Yes. Thank you. Am I audible?
Yes, ma'am.
Okay. Good morning, everyone. I'll be presenting on weight changes and its determinants among sputum positive pulmonary TB patients in Bengaluru, a prospective study I'm Dr. Manasa Divakar, postgraduate in Community Medicine Department. Coming to introduction, weight changes indicating undernutrition has a bidirectional relationship with TB. Undernutrition is an established risk factor contributing to an estimated 55% of annual TB incidence in India. Positive weight changes without additional nutrition support are in the range of 3 to 4 kgs. And undernourished patients with TB get into a vicious cycle of worsening disease and undernutrition, which can be detrimental. So the objective of this study was to assess the weight changes and its determinants among newly diagnosed drug-sensitive smear-positive pulmonary TB patients. Coming to the materials and methods, this was a prospective study with sample size of 121 in newly diagnosed drug-sensitive smear-positive pulmonary TB patients on daily regimen and also who are on fixed dose combinations. And my study subjects were more than or equal to 18 years. They were recruited from selected TB units and their peripheral health institutes in BBMP area. The tool used was pre-tested semi-structured questionnaire, and the method of data collection was after obtaining the informed consent, the tool was administered. Weight and height was measured using digital weighing machine and measuring tape at the recruitment, and the same patients were followed up for weight assessment at the end of 2 and 6 months. Statistical analysis, the quantitative variables were measured using mean and standard deviation as well as median and IQR. The association between underweight and its determinants was seen using chi-square and logistic regression to test the significance, as well as we used repeated measures ANOVA to see the statistical difference in the weight changes between the groups. Among 121 cases, 57.9% were males. The median age of the study subjects was 37 years. The mean weight was 55.72 kgs plus or minus 8.9 kgs and height was 159.5 plus or minus 7.2 centimeters. The mean weight gain was 22.3 kgs plus or minus 1.4 kgs. And at the start of the recruitment, the weight changes increased from 55.72 kg plus or minus 8.9. At the end of intensive phase, 56.7 kg plus or minus 8.5 kg. At the end of continuous phase, 58.2 kg plus or minus 8.2 kg. This weight change was statistically significant. And the BMI also increased proportionately. We also looked to the Nikshay Poshan Yojana monthly deposit, which was received in 69.4 subjects at the start of the treatment and increased to 88.4% at the end of the treatment. The utilization of the money for the same, especially for food, was seen in 28.5% at the start of the treatment and increased to 38.3% at the end of the treatment. So, and the weight change was significantly associated with alcohol consumption, tobacco use, clubbing, and pallor in the univariate analysis, while presence of pallor and tobacco use was significantly associated in the multivariate analysis. The strength of the study was we followed up the weight at the end of the intensive phase as well as the continuous phase, which may give the complete picture of the weight changes. And the limitation was we didn't assess the complete dietary intake in terms of calories, which is the actual representation of the nutrition changes. And concluding, positive weight changes is one of the prognostic factor for successful treatment. Weight changes in the study is 1.1 to 3.6 kgs, which is suboptimal. Therefore, additional nutrition support and counseling is critical for optimal weight changes during the treatment course. So we recommend that the regular monitoring of weight in TB patients with proper nutritional counseling is important to achieve successful outcomes in TB, NTEP. And these are my references. I would like to acknowledge Community Medicine Department staff of Ramaya Medical College, as well as the senior treatment supervisors, the TB HVs and TB patients under BBMP Bengaluru. Thank you one and all. Thank you for the opportunity given for the presentation. Thank you.
Naveen?
Jayashree, go ahead.
Yeah, again, with regard to recommendation, Dr. Manasa.
Yes, ma'am.
Your multivariate analysis shows tobacco and pallor as the attributing factors for low weight gain, isn't it? But your recommendation is on nutrition counseling. How does it correlate?
Sorry, ma'am.
So you need
would actually Yes, ma'am. I would actually advise for the lifestyle change as well as the proper nutritional supplements for reduction in undernourishment.
Yeah. I don't know. I have one more query. Somehow, rather than taking the mean weight gain, if you had taken the average weight gain, I mean, the proportions in terms of how many of them had actually initial low weight and then their BMI increased, so proportion of people who had weight gain would have been better. That's what I feel. Somehow there will be a nullification factor if someone has lost weight and some others have gained weight. That is my opinion. I don't think this is the correct statistic to be used when you're using mean weight gain. That is one more thing. Others may pitch in if they think they differ from my thought. Dr. Navi, what do you say?
I agree with you, Dr. Jayashree. Probably because some outliers, what we call in community medicine, can definitely pull your nutrition into either ways. So you could have looked at the individual weight gain, as Jayashree said, and looked at or classifying them who were into very low BMI, and then you could have looked at whether how much was the weight gain in them. Probably would add more value, Dr. Manasa.
Yes, sir. Sir, I would like to mention that I had also looked at the like less than 18.5 BMI subjects. So the prevalence was 25% in my study, and the increase in the weight was around 4% from the start of the treatment till the end of the treatment.
In people with BMI less than 18.5, is it?
Yes, sir. The weight gain was around 4%, sir.
Okay. 4 units, you mean to say?
So I actually like from the weight gain I calculated. So like the total weight gain, and then among that proportional weight gain I used, and around 4%, 4 units is what we can say.
Okay. Was there any other factor which played a role in the outcome?
So yes, sir. So I had asked for the socio-demographic details, and even the date of start of the treatment or end of the treatment, as well as the factors affecting like housing conditions, everything I had asked.
Okay. Do you think any other underlying conditions could also have interfered with the
Yes, I
nutritional
had
gain?
also looked after. I had also looked into the comorbidities like diabetes, hypertension, and cardiovascular diseases. But specifically for weight change, I did not get those factors as significantly associated. So I couldn't mention in this particular poster, sir.
Good, Manasa. I think both people you have done well, and best of luck.
Thank you, sir. Thank you so much, sir.
Thank you, Dr. Manasa. Thank you, judges. Is Dr. Sushma ready to present?
Yes, I'm ready.
We'll make you the presenter.
Oh.
Ma'am, are you able to share your screen?
Yes, I'm sharing.
Thank you.
Is my slide visible?
No, ma'am.
Now?
Ma'am, can you share your entire screen and then go to the PPT?
I'm done. No, the other posters.
Slide share.
I'm not just saying this
Share.
like give us more. Because that lady was not satisfied with my presentation.
Share after. Okay, share that PPT only. I'll present it.
Ma'am, shall we share?
Yeah, share.
Okay.
Is my PPT visible now?
Yes.
Okay. Good morning. I'm Dr. Sushma, postgraduate from the Sri Devarajaras Medical College. The title of my study is Knowledge, Attitude, Practice of Hand Hygiene Among Rural Population of Kolar. There is evidence that COVID-19 virus is transmitted through respiratory droplet or contact. Due to COVID-19 pandemic, the WHO and other major authorities recommend for hand wash as one of the cheapest, easiest and most important ways to prevent the spread of virus. The hand hygiene behavior and its effect on illness like diarrhea, respiratory infection, etc. are issues of growing importance. The knowledge level and the hand hygiene behavior of the general population is relatively limited. The understanding on the knowledge gap and public towards hand hygiene, thereby providing information on health promotion activities and campaigns to improve hand hygiene compliance. With this background, I planned a study with the objective to assess the knowledge, attitude, and practice of hand hygiene among rural population of Kolar. This is a community-based cross-sectional study, and this was done in a Cambodi PHC, Kolar. The study population were all the adults residing in villages of Cambodi PHC, Kolar at the time of study. My sample size was 267. Assuming 50% of awareness and with 6% absolute precision with 95% confidence interval, the minimum sample size was calculated to be 267 using OpenAPI. The study was done for 3 months. I've used pre-tested semi-structured questionnaire. The data entry was done using Epidata software and analysis was done using SPSS 20 version. The study participants, the mean age of the study participants were 52 years. And the table 1 showing the socio-demographic characteristics of people in rural area of Kolar with samples as 267. The majority of the study participants were males, that is 64.3%, and about 67.9% were employed, and 46.7% were having no formal education, and around 37.7% were belongs to class 2 BG Prasad classification. This is a figure 1 showing the knowledge, attitude and practice of hand hygiene. About 80% were having good knowledge about the hand hygiene and were having good attitude towards it, and 85.84% were practicing. About 60.6% of them have washed hands with water 4 to 8 times per day, and about 46% have washed their hands with soap 1 to 3 times per day. 41% felt washing hands with soap is troublesome. To conclude, the conclusion of the studies, the hygiene practice and behavior were not as highly complied as expected. With this, I would like to recommend future interventions should focus more on advocating sustainable behavior of good hygiene by having more activities through village health and sanitation committees. These are my references. Thank you.
Dr. Naveed.
Okay, thanks, Jayashree.
Yeah.
Thank you, Shishma. What do you think are the reasons why your results were so poor, or people did not believe in hand washing?
Sir, illiteracy is the main reason. So one of the reason there were no formal education, and about 37.7% were belongs to class 2. That could be the reason, sir.
Okay, how do you think there was no COVID at all in that area, and then people did not believe in hand washing?
No, sir.
What was the prevalence of COVID in that PHC area? Any idea?
COVID.
Were there any positive cases? No, you don't have any idea.
No, sir.
Okay, thank you.
Yes, Dr. Sushma.
Yes,
First question, you have mentioned all adults residing in villages of Cambodi PHC. You have only 267 adults under your Cambodi PHC?
Ma'am, in PHC, under Cambodi PHC, there were 14 villages, ma'am. From them, I've randomly selected 4 villages, and in that 4 villages, I've done systematic random sampling, ma'am.
Then you should have mentioned that. You should have mentioned that sampling. thing. And then, yeah, but I personally feel 81% knowledge and attitude and 85% practice is pretty good, actually. I don't think it is poor practice. And here you are noticing something strikingly different is one is KA is poorer than the practice.
Yes, ma'am. Without
So what do you
their knowledge,
attribute that to?
without their knowledge regarding it, they were practicing, ma'am.
Uh-huh. How is your data regarding washed 8 times a day and 1 to 3 times per day with soap useful?
Ma'am, I administered two questions, ma'am. How often do you wash your hands a day? I had given four options, ma'am.
Do we have a standard protocol as in how many times we need to wash hands a day? Is it
Uh,
dependent on the occupation
yes,
or
it depends on their occupation, ma'am.
then have you associated with that or you have taken
Um,
one size fits everybody and said how many times they need to wash?
for everyone, I have administered the same, ma'am.
Same thing. Okay, fine. Thank you.
Thank you, ma'am.
Host, you can take over. Yeah.
Thank you, Dr. Sushma. Thank you, judges. Yeah, we request all the participants and judges to turn on their camera for a group photo.
Um,
We request all of you to turn on your cameras.
Hi, Bhumika and Prakriti. Probably my camera might not work, so it should be okay. Don't worry.
Can all the other participants turn on their camera as well?
Okay, when they are doing that, we would like to thank, on behalf of Jayashree also, I'd like to thank both Bhumika and Prakriti and Anantram, even though he's not here.
Thank you.
You did a good job, both of you. And then we wish you good luck in the coming years.
Thank you, sir.
Yeah. Thank you. Thanks, everybody. And I especially congratulate all the presenters. A good attempt. Keep doing good job and bring out better studies. Thank you.
Thank you.
Yeah. May we exit?
All the participants turn on their camera. Can you please turn it on just for one quick frame? Dr. Pushpa, Dr. Sushma, Dr. Kavita, Dr. Shabina, Dr. Niveta.
Hello.
It will just take.
Hello.
Yes, ma'am. Dr. Pushpa and Dr. Niveta, please turn on your cameras.
Once again, we'd like to thank all the contestants for this wonderful session, and we'd like to thank the judges for their valuable feedback and guidance. Yeah, you can exit the session now.
Thank you.
Thank you.
Thank you all. Bye.
Thank you.
Bye. Bye, Dr. Nabil. Thank you.
ಆಕಾಶ್ ಇಲ್ಲೇ ಕೂತು ಏನ್ ನೋಡ್ಬಾ ಇವ ಏನಂತ ಹಾ
ಪಾಯಿಂಟು
ಬಂದಿಲ್ಲ ನೀನ
ಯಾರ್ದೋ ಆವಾಜ್ ಬರತ್ತಿಲ್ಲ ಮ್ಯೂಟ್
Good afternoon, everybody.
Good afternoon.
Yeah, I'm Dr. Renuka. I'm logged in under the ID of Usha Rani. Okay. So I request the organizers to start as everybody is
Wait a
logged
sec.
in, right?
Yeah, ma'am. Yeah, okay, ma'am. But your name, ma'am, can you kindly tell your name, like which
I'm
present?
Dr. Renuka. I'm Dr. Renuka.
Renuka. Actually, you have logged into a wrong ID, ma'am.
No, I'm Dr. Renuka. As a judge, I have logged in here under Usha Rani.
Okay, ma'am. Okay, ma'am. Okay, thanks, ma'am.
Right thing. It is the right. Okay, the presenters list is with me. Okay.
Yeah, ma'am. Thank you.
My
Thank
ID
you,
is showing as Usha Rani.
Okay, ma'am. Okay.
Yeah. Thank you.
Hey, video in no preference.
You ask them now.
Hello. I'm one of the presenter named Dr. Asha Bellat. Sorry, I have logged in through my son's name, Akash Bellat.
Yeah, ma'am. We are
Is it
your name.
okay?
Yes, ma'am. Yes, ma'am. It's okay.
Huh.
But kindly tell your name before presenting because the
Yeah.
just ask your name.
And I'm unable to start the video. Oh, is that a problem with me or from your side?
It's from your side only. Like twice.
Uh-huh.
You
Just
can
trying
log
to.
out and come log in again if you are not unable to connect properly.
Okay. Okay. Thank you. Hello. Is it okay if the video is off or should I log in from my mobile? There's some problem with my system. I'm not understanding why video I'm not able to log in.
The judges will get the program by this.
Sorry?
Ma'am, can you give us 1 minute? We'll come back to you. 1 minute.
Okay.
So good afternoon, everyone. Now we are going to start our session number 14. So welcome to the 32 state level annual conference of Karnataka Association of Community Health hosted by Ramaya Medical College. The theme for this year is redefining public health, COVID-19 and beyond. So with this, we shall begin with our session. Session 14, Faculty Oral, MCH and Infectious Diseases. Myself, Prachi from Ramaya Medical College, 7th term MBBS.
Myself, Priya Holamani.
So we both are going to conduct this session, and we are thankful for dedicating your precious time to judge these sessions.
Today's session will be moderated by Dr. Renuka, Professor in Saptagiri Medical College, Bengaluru, and Dr. Pallavi, Professor and In-Charge Head, Rajiv Gandhi Institute of Public Health and Center for Disease Control. So let's go through the instructions. Download the WebEx application before for smooth functioning. Log in 10 to 15 minutes early. Make sure you have uninterrupted internet connection. Make sure you enter WebEx meeting with the name, your name. Make sure your camera and microphone are functioning properly. Make sure you are seated in an isolated and closed space with proper lighting. Mute your microphones when you are not speaking. Minimize distractions from the background and avoid echo. Stay seated and stay present. Stick to the given time frame. Your presentation will be stopped if you are exceeding the given time. The time is 6 minutes for the presentation and 2 minutes for the question and answers. This question and answers is for the judges. Next, we request everyone to kindly cooperate to successfully conduct the event. Thank you.
The 5 minutes will be given for your presentation and 1 minute will be given to conclude your presentation. So make sure we will inform you in between your presentation. Only 1 minute left and we will inform you at that time.
Yeah, let's start the session with the first participant named Dr. Lakshmi Kalbandakeri. We will on the PPT, ma'am. If you are sharing, we'll give access to your PPT. One minute.
Wait a second. Sorry for the delay.
Yeah, can we give the access to you, ma'am, or should we present the PPT?
We are calling Dr. Lakshmi Kalbandakeri. Can you hear us, ma'am? Are we audible for you?
Sorry. Dr. Lakshmi Kandalbankeri, are you there, ma'am?
We can't hear you, ma'am.
Dr. Lakshmi Kandalkeri.
She is not here. Then now we are going to the next participant, the second participant of our session. She is Dr. Asha Anil Bellar. So, yes, ma'am.
Yeah.
Can you unmute
Yeah.
yourself?
Yeah, ma'am. We'll present your PPT, ma'am.
Yeah. But sorry,
One
my
minute.
video is off.
Yeah, ma'am. Yeah, we'll. It's okay, ma'am. If your video is on, we'll
Okay.
present your PPT.
Fine.
Yeah, shall we give the access to your PPT, ma'am, or we present?
Yes, yes, yes.
I'll give the access to you, ma'am.
Huh.
Akash Bellad, right?
Yes, yes.
Yeah, ma'am. You got a. Yeah, you have to present now, ma'am.
1 second. Not it. Okay, I should display my PPT right now.
Yes,
Is
ma'am.
it seen?
No, ma'am.
Is
Not
it seen?
You should tell the share and share the screen.
Share, madam. 1 second. Share, madam. Is it seen? Are you able to see?
Yes,
ma'am. Yes, ma'am.
Okay. Shall I begin now?
Yes, ma'am. Your time starts now.
Okay. Good afternoon. Sorry.
Yeah,
Good afternoon. Good afternoon, everyone. Myself, Dr. Asha Nilbalad. I'm Associate Professor from Jain Medical College, Belgaum. The title of my study is Assessment of Knowledge and Practice Regarding Menstrual Hygiene Among Adolescent Girls of Rural Area, Belgaum, Karnataka. It's a cross-sectional study. Coming to the introduction. Menstruation is generally considered as unclean in Indian society. Isolation of the menstruating girls and restrictions are being imposed on girls in certain areas and family. Good hygienic practices such as the use of sanitary pads and adequate washing of the genital area are essential during menstruation. There is a substantial lacuna in the knowledge about menstruation among adolescent girls. Most of the adolescent girls had incomplete and inaccurate information about menstrual physiology and hygiene. So the objective of my study is to assess the knowledge and practices regarding menstrual hygiene among adolescent girls of rural area. Coming to the materials and methodology, it was a cross-sectional study which was conducted in the field practice area of our college. We are attached to 2 primary health centers, so the study was conducted in those areas, that is Kini and Vantpuri in Belgavi district, Karnataka. Study sample included 320 adolescent girls from the above mentioned areas from 7th to 10th standard, first PU, second PU. So they were included in the study. Study period was from Jan to February 2020. A pre-designed and pre-tested questionnaire was used to collect the data. Girls were included in the study after only obtaining informed consent from them. So the inclusion criteria included all those girls who had attained menarche and who gave consent. So the results, demographic characteristics, age group. In our study, majority, that is 65% of participants belong to age group of 13 to 15 years with a mean age of 15 years. Religion, majority were Hindus. Mothers' education, majority of respondents' mothers were illiterate. That is around 50%. Age at menarche, the mean age at menarche was found to be 13 years. The majority of females attained menarche at the age of 14 years, followed by 13 years. Knowledge related variables, source of information. In majority of respondents, that is around 68%, the source of information was from mother, followed by teacher and friends. Knowledge regarding cause of menstruation, around 67% of them knew that menstruation is a normal physiological process. 2.1% thought that it was pathological. Another 2.1% of them thought that it was as a result of curse from God, and 25% did not know the cause. Knowledge regarding blood flow, only 46% of respondents correctly reported that the organ of blood flow during periods was from uterus. 40% of girls did not have the knowledge about organ of blood flow. Knowledge on interval between 2 cycles. Majority of the participants did not have the correct knowledge on interval between 2 menstrual cycles. 22% did not know the interval between 2 menstrual cycles. Moving on to practices regarding menstruation and hygiene. The absorbent used during menstruation, around 73% used sanitary pads, 19% used new cloth, and 3.3% used old cloth. Frequency of changing pads per day, majority of them practiced good hygiene, that is, changed their pads more than 3 times a day, and 40% changed their pads less than 3 times per day. Disposal of pad after use, majority of them followed good practice of disposing pads in the dustbin. Restrictions during menstruation, majority of the girls, that is around 90%, said that they had restriction in doing religious activities, and 59% were restricted from playing. 48% were restricted from doing household work. 25% were restricted to move in the house freely. 16% were restricted entry into the kitchen, and 33.2% were not allowed to attend marriages and balls during menstruation. So to conclude, the study reveals that menstrual hygiene is still far from satisfactory among adolescent girls. Thus, the above results of the study reinforce the need to encourage safe and hygienic practices among adolescent girls. More and more health awareness program and health talk are needed. So the recommendations are mothers should be educated more so that they can change their misbelief, misconceived ideas, wrong practices, and negative attitudes related to menstruation. menstrual hygiene, as they are the important source of information to their daughters. Provision of sanitary toilets in the schools with accessible safe running water supply and covered dustbins to dispose the used sanitary napkins and pads should be made available in schools and colleges. These are my references. Yeah, that's
1
it.
minute is left to complete.
Sorry?
1 minute is left to complete.
Yeah, already given my conclusion. So more and more health talk and awareness programs are required to increase the knowledge of our adolescent girls towards improving their hygiene, menstrual hygiene. Thank you.
Judges, you can ask the I'm giving 2 minutes for question and answers.
Yeah. Can you just substantiate the need for your study in today's contest?
In rural areas, in urban areas, actually, there's in schools itself, there is a lot of awareness programs being organized in urban area schools, right from sixth standard itself. Team of doctors or healthcare workers go and educate the girls about. They impart knowledge about the hygiene and other things, but it is still lacking in rural areas. So that's why I feel this has to be carried out on a larger scale, on a bigger geographic area. Find out how much is the current knowledge of our adolescent girls in rural area, and then implement certain things. You can plan certain programs to improve their knowledge and practices.
Over to you, Dr. Pallavi. Dr. Pallavi, over to you. Yeah. See, what we feel is even 10 years, 15 years back when we did the study, the situation remains the same. There is no change.
Yes.
That means it's wrong from our side. Nothing has been
Yeah,
done
yeah.
from our side.
Yeah, we need to improve
Yeah,
our IEC activities a lot, madam. So it is not being
Hello.
done.
Yeah. Over to Dr. Pallavi. Yeah.
Yes. Dr. Akash Bellat. Yes.
Huh.
Thank
Yes, ma'am.
you for the presentation. Yeah, I just
Yes, ma'am.
wanted to ask you, can you just please take us through your sampling method and statistical analysis?
Yes. So I told you we have two centers, primary health centers. One is in Vanpuri and Kine. So the study was conducted on an OPD basis, ma'am. So whoever came to our OPDs in both the health centers for the 2 months, the period of 2 months, so all of them were included between the age group adolescent girls. So it was a OPD based study, center
So
based
what was the
study.
sampling technique?
A universal sampling, ma'am. All those girls who had attained menarche and who were in the age group of adolescent, all were included. So it was like universal sampling.
Sorry for the disturbance, ma'am. Your time up. So now,
Thank you for the presentation, ma'am. Let's move to the next participant. That is Dr. Purnima Baswaraj Koth.
that was such a great presentation, ma'am.
Can you please stop sharing your presentation, ma'am?
Yeah.
Ma'am, actually you did not stop sharing. You have to stop sharing completely, like the screen also, ma'am. Or else we cannot present, the next presenter cannot present her screen.
Can you hear us, ma'am? Dr. Asha, ma'am?
Yeah, one second.
Sharing, ma'am.
Is it done now?
No, ma'am. You actually should log in, ma'am. Sometimes it doesn't go sharing thing.
There is some internet connection issue, ma'am. You just log out once and
Log out. Okay.
Yes. Again log. Next presenter, Purnima Baswaraj Koth. We are presenting your PPT, ma'am. 1 minute. Can you hear me, ma'am? Purnima, Dr. Purnima. The next presenter is Dr. Purnima Baswaraj. Can you please unmute? Dr. Purnima Baswaraj, can you please unmute?
Ma'am, you are not audible, ma'am. So now we go to the fourth participant, that is Dr. Akshaya KM. Sir, can you please?
Hello.
Who is this, ma'am? Can we know your name, please? Is this Dr. Purnima Baswaraj?
Yes. This is Dr.
Sorry, Akshay sir. Actually, third participant is Dr. Purnima. She was not audible before. Now her presentation. So,
we will share your PPT, ma'am. 1 minute.
Okay.
Should we give access to you, ma'am?
Yes, please.
Yeah, ma'am. 1 minute. Yeah, ma'am. You can present your PPT now.
Can you see the PPT now? Hello?
No, ma'am. No, ma'am.
Okay. 1 second. Share. Now, ma'am? Can you see the PPT?
Yes, ma'am. Yes.
Okay. Good afternoon, everyone. Shall I start, ma'am?
You can start, ma'am.
Your time starts now.
Okay, shall I start? Good afternoon, everyone. This is my study on comparative study on unmet needs of adolescents among rural and urban communities of Hassan, Karnataka. The disability consists of structural impairment, activity limitation, and participation restriction. So, according to disability statistics in 2016, it was found that the prevalence of disability in India was 2.21%, and the highest disabled population belonged to the adolescent age group, that is 17%. Hence, what we did was there were many studies conducted among adolescents to assess the needs of the adolescents. Hence, it was found that nutrition, education, healthcare access to healthy living, sanitation, employment, and attaining an independent and social maturity were the needs of the adolescents. Hence, if these needs were provided to the disabled adolescents with an accessible environment, they can make the optimal use of their skills and energies to be a responsible people of the society. Hence, the study was conducted with the objectives to assess the socio-demographic characteristics of the adolescents, to determine the extent of disability types, and to assess and compare the unmet needs of disabled adolescents. Coming to materials and methodology, it was a cross-sectional study conducted in urban and rural field practice of Hassan Institute of Medical Science, that is UHTC and Shanti Grama, with 5 sub-center each. All the disabled adolescents in the study area were included in the study. It was a 2-stage cluster sampling. The study was conducted from July 2018 to 2019, June. The method of data collection was after taking a prior informed consent from the parents and assent from the adolescents aged 12 to 19 years. The adolescents were interviewed at the place of residence using a semi-structured pre-tested pro forma. The details regarding activity limitation and participation restriction was collected using modified ICF checklist version 2003. Inclusion criteria: all the disabled adolescents, irrespective of their gender and type of disability. All the adolescents who gave assent and consent for the study. Exclusion criteria was disabled adolescents who were not available even after 3 visits. Data was analyzed using SPSS software version 20 for descriptive statistics, bivariate and multivariate cross-district registration. Coming to the results, there were totally 68 disabled adolescents in the study area with an attrition rate of 10.29. Only 61 adolescents were included in the study, among which 33 belonged to rural area and 28 belonged to the urban area. Studying the association of various socio-demographic characteristics and locality of the disabled adolescent, it was found that early adolescents and the type of family to which the disabled adolescents belong played a majority role and affected. Even the disability severity also played an important role, and there was significant association between the locality and disability severity. Among the when studied for distribution of according to their disability, it was that mental disability was most common and followed by the multiple disabilities. Association of various factors for socio-demographic characteristics of disabled using multinomial regression, it was seen that transportation services, education, societal attitudes, building structure played an important role as a barrier, especially among rural areas and inaccessible structures of the buildings. Coming to the conclusion, it was found that the study most common disability was mental disability, followed by the multiple disabilities. There was significant association between local and the socio-demographic characteristics like age of the adolescents and severity of the disability. Coming to the barriers, there were transportation, which was 60.7%, building structure 57.6%, societal attitudes 57.6%, communication services 55.7%, acted as a significant barriers. Coming to the limitations of my study, self-reported data was relied upon, which has the chance of recall bias. These were my references. I would like to acknowledge all the adolescents and parents who voluntarily participated in the studies and all the ASHA workers who helped me to approach the adolescents. Thank you.
Much. We are
Such a great presentation, ma'am.
We are handing over to the judges. You have 2 minutes to ask question and answers.
Okay.
Dr. Pallavi, you start first. Dr. Pallavi?
Hello. Dr. Purnima Basavaraj.
Yes, ma'am.
Yeah. Good. It's a good topic actually to take up study.
Thank you, ma'am.
I just wanted to know, how did you get the data regarding the disabled people? In the sense, how did you
Ma'am, disability, I went to the social welfare department from where I collected the list of the disabled adolescents. And then I approached the ASHA workers to find out the adolescents from each area,
Okay.
like including the Anganwadi workers also. So they knew the disabled adolescents in that area as well as their sub-centers.
And can you please explain what is two-stage cluster sampling?
And first I collected the list of the disabled adolescents in the first I collected the sub-centers areas of the sub-centers in the 2 area, ma'am. And then I collected the list of the disabled adolescents in those areas. Then I listed them according to the type of disability and collected the data, ma'am.
Sampling.
Hello?
Hello, is it a purposive sampling or random sampling?
Hello, am I audible, ma'am?
Hello,
Hello.
can you hear me, please? Yeah. Is it a purposive sampling or random sampling?
Ma'am, purposive sampling.
Then the cluster, okay,
Hello.
fine. Thank you, doctor.
Thank you, ma'am. Thank you. Thank you. It was a great presentation. Let's move to the next presenter, Dr. Akshaya KM. Dr. Akshaya KM. Ma'am, please start sharing your PPT.
ಇದ್ರಾಗ ಮಾಡ್ತೀನಿ ಬರ್ರಿ. ಹೌದಾ? ಬರ್ರಿ ನಾನು ಮಾಡ್ಕೊಡ್ತೀನಿ.
Ma'am, can you please stop sharing your screen?
1 second, ma'am.
Yes.
Oh my God.
Yes, ma'am. Can you please, like, the next presenter is waiting. Hello.
Can you hear us? Are we audible, ma'am?
Hello.
Hello. Can you hear us, ma'am?
Ma'am, please stop sharing your PPT, ma'am.
ಅದು ಶೇರ್ ಹೆಂಗ್ ಚೇಂಜ್
Log out once and then log in.
Log out once. Able to stop.
Okay, ma'am. Okay, ma'am. Is it fine now?
No, ma'am. It's not shared. It's not stopped yet.
Dr. Purnima, ma'am.
Share is ಮಾಡಕತ್ತೀನಿ.
Once and then come back for the meeting, ma'am.
Ma'am, if you are unable to stop sharing, just log out completely, ma'am. Or else it will be delayed to the next presenter, ma'am. Kindly, please.
ಲಾಗ್ ಔಟ್ ಆಗನಕತ್ತಾರ ನಿಂಗ. ಇದು ಹಾಕು ಕೇಳಿಸುತ್ತೆ. She's unable to log out.
Ma'am, you can unable
Dr.
to.
Purnima is unable to log out. How to log out?
Wait, ma'am. Like we are trying to.
Ma'am, just can say there will be one cross option, ma'am. That option just at the right side of you. You just. Wait.
Yeah, ma'am. Yeah,
Yes,
ma'am. Thank you, ma'am. The next presenter is Dr. Akshaya KM. The presenter is there, Dr. Akshaya KM.
It's not audible.
Dr. Akshaya KM. Can you unmute?
Leave the meeting, madam.
Akshaya KM. Yeah. Sir, can you, we'll give access to you, sir. You share. Sir, we are not audible, sir.
You are not audible, sir. So unmute yourself. So I think there is some problem with your mic, sir. So please check it once. No, sir, you are not audible.
Sir, do one thing. You can log out and log in back, sir. Or use your microphones or headphones, any of those. You are not audible, sir.
ನಿಂದು ಹೋಯ್ತು ನಿಂದು
Sir, you are not audible, sir. No, sir, we are not
Sir,
audible.
please just connect your earphones. Might be you will be audible at that time. That time we are giving the chance to Dr. Lakshmi Kalbankeri ma'am. Actually, she was the presenter, and yes, ma'am, you can present now. So she was the first presenter for this session, and she came late, so we are giving access to her.
Ma'am, we are giving the access, ma'am. 1 minute.
Okay.
We are making you a presenter.
Ma'am, please turn on your video.
Yeah, ma'am. I request all presentees to turn on your videos while presenting.
Yes.
Thank you for coming, ma'am.
Yeah, I had some internet issues.
Ma'am, you
no
can.
worries, ma'am. So, ma'am, you can. Sorry, Akshay sir. Actually, we started with the Dr. Lakshmi ma'am. So she will present now. You are not audible. You are still not audible, sir. So we can't hear you.
Yeah, sir. Till that, the Lakshmi ma'am will be presenting. Can you please?
Sir, please try to connect your earphones, sir.
Try to connect your earphones.
So you type once whatever you're saying. No, we are not.
You are not
we can't
audible,
hear,
sir.
sir. You are not audible, sir.
Try typing.
So type whatever you want to say.
Yes, ma'am. You can present, ma'am. We have given access to you.
See the screen.
Ma'am, we gave access to
We
you.
have given access to you, ma'am. You have to present your PPT.
ಇದು ಶೇರಾ
You have to share, ma'am. Yes, ma'am.
ಯಾವುದು
Share the screen and present your PPT. Yes, ma'am. Yes, ma'am. Not this screen, ma'am. You have to share your PPT. Yeah, ma'am. It is sharing, ma'am. Yeah, ma'am. It's visible.
Can I start?
Yes, ma'am. Kindly.
Good afternoon, everybody. I'm Dr. Lakshmi Kalbankeri. I'm presenting my study on immunization coverage status and the reasons for the partial immunization among urban slums of Kalburgi city of Karnataka. Coming to introduction, immunization is one of the most cost-effective interventions sickness through sickness, disability, death. Today, reach out to over 100 millions of the children every year. Immunization services do not reach to over 1/3 of the population, and only 43% are fully immunized. The urban population is highly differentiated, and pockets of poor coverage and high incidence of vaccine preventable diseases still exist. So there was a need to review the current strategies to make sure that every child receives the routine immunization. Therefore, the study was planned to estimate the immunization coverage and to find out the reasons for partial and non-immunization status of the children among the age between 12 to 23 months in the urban area of Kalburgi. My objectives of the study were estimation of primary immunization coverage of children aged 12 to 23 months, and to determine the reasons for the partial my materials and results were, it was a cross-sectional study which was done in the urban city of Kalburgi area and was done between January and December. My study population were children in the age group of 12 to 23 months. The data was collected using pre-structured and pre-tested questionnaire method after obtaining the informed consent from the parents. The inclusion criteria included the children between the age of 12 to 23 completed months as on the date of the study, and the exclusion criteria were the children below 12 months and above 23 months, and those mothers or parents who were not willing to participate in the study. The sampling technique used was the WHO cluster sampling technique. My sample size was 450, as we took a design effect of 5.67 than the usual 210 sampling method, and ethical clearance was obtained, and data analysis was done using percentages square test using the SPSS version 16. Coming to results, the social demographic details of the participants, we saw that the majority of the children were there in the group of 12 to 23 months, or 21 to 23 months, followed by 12 to 14 months, and followed by 54% were in males and 45.3% were females. Majority of them belong to Hindu religion, and 68.9% belong to the OBC category. And according to the socioeconomic status, majority belong to the class 4 classification, and majority belong to the nuclear family. Coming to the distribution according to the immunization status of the children, 74.2% were fully immunized, 24.9% were partially immunized, and 0.9 were non-immunized children. The reasons for failure of complete immunization accordingly were classified into lack of information, lack of motivation, and obstacles, and among which the majority was lack of information, followed by obstacles and lack of motivation. Coming in detail for the individual reasons, among the lack of information, majority was they were unaware of the need for immunization, followed by fear of the side effects. And among the lack of motivation, majority of the parents or mothers, they told that they postponed until another time, or they had heard some rumors about immunization and related things. And coming to the obstacles, majority of the mothers told that they did not get the child because the child was ill, and reason was that mother was too busy, so she wanted to take the child for the next session. So, coming to conclusion, sustained improvement of immunization coverage levels can be attained by concentrating on the reasons which are influencing the utilization of immunization services, by addressing the issues of the lack of information, obstacles, and lack of motivation reasons. We can improve these by the behavior change communication interventions.
Thank you, ma'am. Now, 2 minutes time for the judges. You can ask the question.
Yeah, yes, Dr. Lakshmi. When did you do the data collection?
Ma'am, it was in 2016, ma'am.
Oh, it was in 2016. Okay. Yeah, but then now the values would have changed, no? So now
Yes,
NFHS
ma'am.
data has come. And could you compare with your statistics with the NFHS data?
Ma'am, I didn't do that, ma'am.
You didn't do that. Okay.
Actually, this study was
Because
after the commission Danish was introduced.
Okay. Now, why I asked is, suppose you have done it recently, the impact of COVID on immunization coverage. So I just wanted to find out about that.
It was not done now.
Okay. Yeah, over to Dr. Pallavi.
Yeah, thank you, ma'am. Dr. Lakshmi, it's really a good topic to take. I just wanted to know, how did you do this cluster sampling technique?
Ma'am, actually, we had 11 urban centers in Kalburgi. Out of that, randomly, I selected 5. And then we line listed all the population. And then we came up to a sampling interval. And then we randomly selected a number, and through which we got a cluster interval. And then adding on that sampling interval to the cluster sample, we selected 30 clusters, ma'am. And in each cluster, I took 15 children, ma'am. That is why my sample size is 450.
Okay. Yeah, you are just one more observation. Like in your title, already you have kind of your hypothesis. You have already made that there is a partial immunization. It is contradicting, the title itself is contradicting, that there is, you are assessing coverage status, but is already you are telling it is partially immunized.
Okay, ma'am. Because my case definitions were like that, ma'am. Fully immunized and partially and non-immunized, ma'am.
Because you are already telling, like in urban slums, it is partial immunization is there.
It's for partial.
Yeah, it could have been just the reasons for whatever the status of
Okay,
immunization or
ma'am.
factors associated with immunization status.
Okay, ma'am. Okay, thanks.
I don't know.
Thank
I
you,
felt
ma'am.
it contradictory. I may be
Okay.
wrong also.
Okay, thank you, ma'am.
Yeah, thank you.
Yeah, and also that SPSS, no, you put version 16 or 21 has come.
Yes, ma'am. Yes, ma'am.
Yeah, yeah. Okay, yeah, thank you.
Thank you very
Thank you, ma'am. Thank you so much. It was a great presentation. Let's move
Thank
to the next presenter, Dr. Akshaya KM.
I should stop.
Am I audible?
Stop presenting,
Yes,
ma'am.
sir, you are audible, sir.
Yes, I stopped.
Yes, sir, you can present your PPT. You are able to present, sir?
Yes, just a minute.
Yes, sir.
Yeah, can you give me a share?
Dr. Lakshmi ma'am, can you please log out once because we are not able to share the screen.
Okay, sir, we'll share your PPT once. Allow the keyboard and all is not coming.
Okay, can you move to the next slide?
Yes, sir. Yeah, no, sir, we are giving the access to you. You can present your PPT.
Okay, fine.
Yes, sir. Yeah, sir, we have given access. So kindly present. Yeah, sir, it's
Am I audible and the slides are fine?
yes, sir, it's everything perfect. Thank you,
Okay,
sir.
thanks. Yeah, thanks the whole MS Ramaya team for having given me this opportunity. I would like to I would like to wish a very good afternoon to the chairpersons as well as my fellow colleagues. So my topic for this presentation is evaluation of Rogi Kalyan Samitis, or also called as Arogya Raksha Samitis in Karnataka, in the primary health centers of Dakshin Kannada district, Karnataka Health Systems Research. So as we all know, community participation is one of the principles of primary healthcare, and decentralization for that matter in administration will help us to strengthen the accountability in government structure. So RKS or Rogi Kalyan Samitis or Arogya Raksha Samitis were introduced under NRHM for improvement of service provision way back in 2005. And funds are released in the form of seed money, untied funds, and grants by private funders as well as charity providers in this particular system. Continuous monitoring of financial and programmatic aspect has to be employed to strengthen the Rogi Kalyan Samitis. Evaluation of such samitis will help the district health administration to nurture the good practices and work upon the deficiencies. So the objectives of our study were to evaluate the functioning of RKS in primary health centers of Dakshin Kannada district, Karnataka, and to identify the barriers and facilitators for the effective functioning of RKS in these PHCs. Coming to the methods, it was a two-phased mixed method study with a sequential explanatory design. It was conducted in all the 65 rural primary health centers of Dakshin Kannada district between April 2018 and September 2019. For the quantitative part, the medical officers were the study participants, and also we reviewed the existing records at primary health centers. For the qualitative part, we involved 10 medical officers for the in-depth interviews, and the in-depth interviews were the duration of the in-depth interviews ranged from 18 to 70 minutes, and the IDI guide was first pilot tested in one of the urban primary health centers. As far as the tabulation and statistical analysis are concerned, we tabulated the data using SPSS 22, and we calculated the frequency and proportions. The transcripts, as far as the qualitative data is concerned, were generated on the same day or within 48 hours based on the notes or audio records. Just to tell over here that we took informed consent for audio recording before we could do that from the medical officers. Manual descriptive content analysis were used to inductively derive the common themes and code, and we referred Creswell's qualitative research methods textbook for this particular aspect. 62 primary health centers, about 90%, had RKS established in 2005 and 10. One PHC had inpatient services. Ayush services were available in 14. 62 were registered under the cooperative societies, and less than half PHCs displayed members. 45 or 85% had 6 to 9 members in the governing mode, and about 50 PHCs had conducted at least 3 to 4 meetings in 2017-18. Characteristics reflecting the functioning of Rogi compliance is we see that most of the PHCs, or almost 100%, had a suggestion box. They had a waiting area for patients and seating arrangement. They provided safe drinking water, and there was a provision of a sanitary toilet. However, we could see that the dedicated ambulance service facility was very poor, as well as there were no alternate referral systems if the patient wanted. So that was poorly observed in our PHCs. However, the display of standard charter of patient rights was found almost in around 90% of the PHCs. So, the summary of the activities or training programs supported by RKS, we could see that most of the funds, as far as supporting activities was concerned, was towards IEC activities and providing refreshments in the meetings as well as training programs. And we could see that it was around 23% of the PHCs had around 1 to 4 trainings, and around 3.1 had around 5 to 10 trainings. We could see that around 1/3 of the PHCs had conducted health camps using the funds from RKS. So when we analyze the contribution of RKS in improving the service delivery in the Dakshin Kannada district, this is as stated by the medical officers. We could see that overall performance of the health center has improved. There is increased availability of drugs and logistics. There has been funds which have been used for disease screening and laboratory services. And we have used the verbatim codes as told by the medical officers in this particular table. Coming to facilitators associated with functioning of RKS in the PHCs, there were two themes which were categorized. One was administrative and second one was community participation. In the administrative part, the support from the district, the decentralization pattern, and the coordination between the members acted as facilitators. Whereas in community participation, we had patient satisfaction, inclusion of local leaders, involvement of the NGOs, which acted as the facilitators. Coming to the barriers, there were administrative barriers and also suboptimal participation from some sections of the community. Inadequate funds released to RKS, irregularity in release of funds, increased pressure and compulsion from the
30
senior
seconds are left
authorities.
to conclude your PPT, sir.
Yeah, apathy from administration and lesser authority for medical officers. These were the administrative issues. So, in conclusion, functioning of PHCs in Dakshin Kannada district was found to be good. Improvement in PHCs after the formation of RKS was seen. Scope for improvement in the involvement of RKS is always there, and we have also summed up the facilitators as well as barriers towards the functioning. And we had some recommendations also towards the district administration to how to improve and how to take care of the functioning of RKS. That's it from my side. Thanks.
Time up, sir. Thank you, sir. Thank you so much. I'm handing over to the judges. The next 2 minutes is question and answers. Judges, you can. Renuka ma'am, you are there? Pallavi ma'am?
Yeah, Dr. Akshay, it was a very good study. I have no comments. Over to Dr. Pallavi.
Yes, same
ma'am.
here, same from my side also. It's a wonderful study. It's the purpose as well as the sampling technique and methodology is well appreciated. Thank you.
Thanks, ma'am. Thanks for your comments.
Such a great
Thank you, sir. It was a great presentation. Let's move to the next
Thanks.
participant, Dr. Anvit HS. Sir, we have already made you presenter. You can present. Sir, present your PPT, sir. We have already made you a presenter.
Just join the audio. Join the audio.
Tell share and share the screen, sir. Then we can see your PPT then. Yes, sir. Yes, sir. Thank you, sir. Thank you so much.
Excuse me.
Yes, sir. Yeah, may I know who is this? We cannot listen to this. May I know who spoke?
Can you hear me now?
Yes, sir. Yes, sir. Sir?
Yeah. Good afternoon. My topic of my presentation is mass drug administration for lymphatic filariasis elimination in 2 districts of North Karnataka, the coverage and compliance evaluation. Lymphatic filariasis is a debilitating and disfiguring disease causing significant socio-economic burden and public health problem in India. In India, the disease is predominantly caused by nematode, Wuchereria bancrofti, and transmitted by a vector female Culex kinque fasciaticus mosquito. Globally, the disease is largely endemic in Africa and Southeast Asian region of the WHO region, which includes India. In Karnataka, 9 districts are endemic for filariasis, which includes Bidar. Koppal is a non-endemic district, but as per the instructions of the Regional Office for Health and Family Welfare, this district was taken up for the focal mass drug administration. Mass drug administration is the key strategy for elimination of the filariasis by interrupting the filaria transmission. India had set up a goal for elimination for filariasis by the year 2020, but it has not happened. Evaluation of the mass drug administration is an important component to ensure proper programmatic implementation. The objectives of the study were to describe the socio-demographic characteristics of the beneficiaries of the MDA program, to assess the coverage, compliance, and the causes for non-compliance. The study was conducted in Koppal and Bidar districts of Karnataka. The study was a cross-sectional type of study. The study period was the data collection at the field was done in the month of November 2019 in Koppal district, January 2020 in Bidar district. The study population include all the sample eligible population who are residing in the study area. Once again, the evaluation was for focal MDA in Koppal district and it was annual MDA in Bidar district. Demographic profile of the study subjects is surveyed 240 houses in each of the district with 175 subjects residing in Koppal district and 968 subjects in Bidar district. Majority of our study subjects were more than 15 years and majority of our subjects were males. The MDA coverage in Koppal district was 95.44% and in Bidar district it was 94.73%. The compliance rate was 91.61% and 93.12% in Koppal and Bidar district respectively. The effective coverage rate was 87.4%, 88.22%. The coverage compliance gap was 8.38% and 6.87%. The drug consumption by DOT was 95.1% in Koppal district and 85.8% in Bidar district. None of the subjects had consumed MDA as divided dose and none of them subjects had consumed an incomplete dose of MDA in Koppal district. Common reason for non-consumption of MDA was that the drug distributor had not visited their home and followed by the out of station and followed by the other reasons mentioned above. And each of these reasons is a multiple response. coverage rate of MDA in both districts is more than 85%, which is the recommended standards for achieving the filariasis elimination. The effective coverage rate, which is the end product to achieve elimination, was also more than 85%, which is a very satisfactory sign. The proportion of consumption of MDA by DOT is much less compared to the recommended coverage in the Bidar district. So the recommendations include effective IEC activities for the beneficiaries and improved training activities for the drug distributors. The drug distributors have to insist the beneficiaries on the on-spot consumption to ensure that the tablets are taken or not. So we are aimed to eliminate lymphatic filariasis by the year 2020, but it has not happened. Hope the elimination happens very soon. Thank you.
Thank you, sir. Thank you so much. It was a great presentation. Now, the next 2 minutes is for the judges. You can ask, ma'am. You can ask the question.
Yeah, Dr. Anvit, please go to the methodology.
Yes.
Methodology slide.
Yes, madam.
Yeah, please go to the methodology slide. The slide.
Well,
Yeah.
yeah, methodology slide is on, madam.
No, the first slide is on.
But here I'm seeing the methodology. Once.
Yeah, because when you were talking, the slides were behind. The slides were for.
They're lagging behind the
Yeah. It was not in line with your.
Yeah, sir.
Can you see it now, madam?
Yes. Yeah, I can see that. Yeah, can you please tell what is the study population? All the sampled eligible population residing in the study area. Can you elaborate on that?
Yes, madam. All study subjects who are aged more than 2 years and non-pregnant women were included as the study participants, madam.
Okay. Yeah, and what was your next slide? Because we could not follow it. Just run through your slides.
Yeah. Can I slide, madam?
Yeah. Okay, so in each you visited, there are exactly 240 houses in both the districts, but you said the entire population was covered.
Recommended.
No, you said the entire population was covered, no? All the eligible population, and how can you find 240 houses in both the districts?
No, madam. We had covered the 240 houses and the eligible beneficiaries in these 240 houses were included.
Okay.
The request from the Regional Office for Health and Family Welfare was to cover 60 houses in each cluster.
Okay. So what is the type of sampling you followed?
We have covered cluster sampling.
That was not mentioned. Did you mention it or we missed those slides?
I think I may not mention it.
Yeah, how did you do that?
Yeah, actually, we went to the district headquarters. And in the district headquarters, we took the line list and the coverage rate was given by them. So among that, we chose the taluk which had high coverage, or one the taluk which had the 3 taluks were chosen for in the rural area, and one and urban was done separately. Among the taluks, all the PHCs were line listed. One PHC with high coverage, one PHC with medium coverage, and one more PHC with low coverage was chosen. And among the PHCs which are chosen, we chose one of the village randomly. And subsequently, when we went to the village, we went to the center of the village, and subsequently, through the currency note, we labeled the roads, and subsequently we chose one lane randomly. And subsequently, after a walkthrough survey, we chose one house, and subsequently, after choosing that house, we tossed the coin, and subsequently, the next house, the direction of the next house was decided.
Okay. So you knew the coverage levels beforehand. You wanted to find out the causes why the coverage is less or more, right?
No, madam. We knew the coverage. We tried to assess the compliance. The coverage was by the district administration, telling that how much percentage of people they have covered. We tried to assess how much subjects have really consumed that.
Okay. Yeah, over to Dr. Pallavi.
Yes, thank you, ma'am. Dr. Anvit, it's definitely a good topic. Yeah,
Thank you,
how
madam.
did you, did you assess the factors associated with the complaints? Was it a part of study?
No, madam. I just assessed the reasons for the non-consumption of the drugs.
Okay. So you didn't consider all the factors.
No, I feel you're contradicting your statements.
Okay, ma'am, thank you. Thank you. It was a great presentation. Let's move
Thank
to
you.
the next presenter, Dr. Maltesh Undi. Sir, can you please stop sharing your screen?
Yes.
Dr. Anil?
Yes. Done. Is it done, madam? Stop.
Yes, sir. Yes, sir. Dr.
Thank
Maltesh Undi, we make you as a presenter. You can present, sir.
Yes. Am I audible?
Yes, sir. Yes, sir.
Okay. I'll be presenting from Google Slides because I have a problem with PowerPoint. So just confirm me if the first slide is visible once you make me a presenter.
Yes, sir. Sure, sir.
Is the first slide visible to you?
No, sir. It is sharing itself.
Sorry. I'll just reshare the window.
Shall we share your PPT, sir, if it is not sharing?
Yes, yes. That would be really fine.
Yes, sir. 1 minute, sir. It will take a minute.
I'll stop sharing from my end. You can present.
Yes, sir. Thank you, sir. Please stop sharing, sir, from your side.
For me,
It
it
did
is
not
showing
stop
as
it.
Sir, log out yourself and log in once.
yes, I will do that.
Yeah. Hello, hello. What is his name? He did not log in. Okay, wait. Stop sharing. We should admit him first. It,
Sorry for the delay, ma'am and sir. We are waiting for Dr. Malesh Undi, sir. We are sorry for the delay, judges, all the delegates.
you know, not by connection.
Start.
Okay. Share. Where is it?
PPT. PPT.
Yeah. Here. I should tell allow and
That pass keyboard and mouse controls
it's
are
not
very
there.
Come
Come to that. Come to that.
Go
second,
here.
second option. No. Sir, can we just present your PPT, sir?
Yes, I will be telling next. You can just change the slide to next. Okay.
Yes, sir. Because we are unable to give access to the user.
No issues. Just can you make it slideshow or full
Yes, sir.
screen? Yeah.
Yes, sir. 1 minute.
Is it visible, sir?
Yes. Thank you. Afternoon, everyone. So our study presentation title is a cross-sectional study to assess awareness of accredited social health activists regarding Kasnur forest disease in an endemic district of coastal Karnataka. Myself, Maltesh Undi, working as assistant professor in Karwa Institute of Medical Sciences. Next slide, please. Yes. KFD. Yes, this slide. KFD also has monkey fever is a re-emerging zoonotic disease caused by KFD virus and transmitted to humans or animals by the KFD virus infected ticks, especially the nymphal stage of the ticks that belong to Haemaphysalis spinigera and Haemaphysalis tertiaris. It is reported only from India, that too in Karnataka from 5 endemic Western Ghat districts, out of which Uttar Kannada, the study area from the district where it is chosen, has nearly 80.73% of forest area with abundant of ticks and wild animals, especially the monkeys and langurs, which harbor in the and reside in the district. Our district shares its border with Shumaga district, especially the Aralgoda village, which was epicenter of KFT outbreak in 2019. With outbreak in the area, we also saw that in previous years, especially in 2015, there was a reported case of Asha died due to KFT. Additionally, there were many presumptive cases of KFT being reported in the district, and who were the frontline workers? These were again the Ashas who were put into the course of action, especially educating the people and getting them to the hospitals or as a preventive measures, take vaccines and other preventive measures to be taken. Next slide, please. Next slide. Yes. The study's primary objective was to assess the knowledge of ASHAs regarding KFD in the selected primary health centers of a KFD endemic district of coastal Karnataka. The secondary objective was set to find out the barriers in training program undergone by these ASHAs in the district in the selected PHCs. Next slide. Yes, this study was a descriptive cross-sectional study done in 3 selected PHC through purposive sampling for KFD. The study duration, there is a mistake actually. The data collection was done from 1st June to 31st July 2019. Later on, analysis and reporting was done, and this study was a part of ICMR STS and it was accepted by ICMR New Delhi. The study population included ASHA residing in these or working under these PHCs for at least minimum 1 year during the study period, and ASHAs who were not willing to participate in the study were excluded. Fortunately, no ASHAs were unwilling to give informed consent. Totally 32 ASHAs were selected in 3 PHCs through complete enumeration, and it was selection of PHCs was again a sampling. The study we had a questionnaire frame, that is semi-structured questionnaire translated into Kannada language, since all the 32 Ashas were well versed with Kannada in addition to other languages spoken in the district. It was by interview technique by the investigators trained in the research methodology. We used descriptive statistics, especially mean, standard deviation, proportion, and percentages, and the analysis was done using Microsoft Excel 2010. Ethical clearance was obtained for the study, following which we started contacting the study participants, and written informed consent was obtained from all the ASHAs before recruiting them in the study. Next slide, please. Here, the table 1 shows that almost all the 3 PHCs had a near equal distribution. That is, the first PHC had 37% of ASHAs and 28% in the second PHC and 34% in the third PHC. Regarding distribution of the study participants related to age and work experience, it's interesting to note that most of the mean work experience was 8 years. With this much of experience, we anticipate that at least satisfactory level or at least adequate level of knowledge has to be present related to the diseases that is endemic in the district. Next slide, please. The figure one, it shows that most of them were aware regarding the transmission of KFD, especially by tick bite. However, it is also interesting to know that irrespective of their work experience, we found that 21% still believed that it is due to monkey bite, probably as a misnomer of monkey fever, though it may act as an amplifier host in the disease cycle. Also, it's really alarming that still nearly 9% of the ASHAs believe that it transmits through mosquito, which has to be corrected later. Knowledge regarding potential exposure zone. Karnataka government declares that the 5 kilometer surrounding area where there is a positive case or there is a monkey death, it is declared as a potential exposure zone. And ASHAs have to know because they have to instill IEC activities as well as vaccination campaigns in this area. Next slide, please. Yes, figure 3 shows that commonly used tick repellents for KFD ASHAs were it was actually fair enough, but 1/3 of them do not know. At least 2/3 of them know that DMP, DEET, or Mylol was available. Dimethyl phthalate is usually available in the PHCs. The probable explanation was few of the ASHAs, in spite of these DMP available in the PHC, because of the irregular supply, they may not be aware of the repellents used for KFD. Knowledge regarding KFD vaccine, it's good that 87.5% knew that there is a vaccine. However, a small proportion, that is 12.5%, did not know that there is a vaccine for KFD. 31.2% knew, just previous line, the last line. Yes, previous. Yes, this slide. 31% knew that all necessary precautions to be taken for the prevention of KFD, whereas nearly half of them, that is 53%, knew all steps to prevent tick bites. This is the area where we have to focus on training of ASHA, because we have many people who walk in and walk out of the forest, or those people who live inside the forest itself. There are deep forest areas, forest fringe areas, as well as urban and rural areas here. We have to focus on this. Lastly, coming to the training aspects, it's interesting to know that
Sir, let us fast. You have
so,
only half a minute to conclude your slide presentation. Sorry.
yes, thanks for reminding. Yes, values are missing here. It's just 15.6% of them had undergone training, and rest of them did not had any training, probably because government usually chooses the talukas or the PHC areas where there has been reported. It is better we train them early rather than after reporting the case. The felt barriers were usually infrequent, short notice, and distance, far away distance, as well as lack of the evaluation. With this, we conclude that majority of ASHAs knew correctly about the common name, causative agent, transmitting vector, or presence of vaccine, but they had poor knowledge regarding the biting or feeding patterns, availability of treatment, commonly available tick repellents, or personal protective measures against KFD, which has to be focused on. With this, we try to recommend that in periodic sensitization programs, addressing the barriers which we have found out, this may be included as a training for ASHA. Next slide, please. Yes, we like to acknowledge ICMR for accepting the project under STS, also the medical officers of the selected PHCs and the ASHAs who participated themselves in the study, as well as the one of the student who actually helped other student in as a part of peer assisted learning, because she had difficulty in speaking Kannada. The other student helped her in learning and talking Kannada. That was quite interesting to learn out of the project. In fact, an undergraduate project has to have such ripple effects. Thank you. Over to you, ma'am.
Thank you, sir. Judges, you can ask the questions. 2 minutes.
Yeah, Dr. Maltesh, could you please go to the methodology slide?
Yes, ma'am. The control is with the organizers. Can you please?
Okay. Yeah, previous one.
Previous methodology. Yes, this one. Yes, ma'am.
Okay. So the study tool, right? When you use the local language, was the tool validated?
Ma'am, we did not validate it as you were asking, but we translated and back translated it and checked it through the pilot study whether it means exactly what it means, ma'am.
Okay, good. And was this data collection done prior to the sensitization program?
There is another aspect, ma'am. We met DS of the district. Actually, they are focused on training only the ASHAs who actually live in that epicenter or near to the epicenter. But these ASHAs, they are not periodically sensitizing. Of course, it's a tendency to deny that they have not trained, but our study found out that only 15% of them were trained. Rest of the 84% were not trained, ma'am, actually.
Okay, so among your study sample, 15% were already undergone training.
Yes, ma'am. The
In your
previous
32
training.
ASHAs.
Yes, ma'am.
In
Yes.
32 ASHAs, among 32 ASHAs, 15% had already undergone training.
Yes, ma'am.
Okay.
Yes.
Okay, yeah. Over to Dr. Pallavi.
Thank you, ma'am. Dr. Maltesh, definitely thank you for choosing this wonderful topic. It's nice.
Thank you, ma'am.
I just wanted to know, is there any difference between awareness and knowledge?
Here, our part, we felt same, ma'am, but in some studies, they choose that probably they may have a subtle difference between knowledge and awareness. But our purpose was whether it was not the textual knowledge which they have, whether, for example, the vaccine, we may have so many aspects like schedule and other things. Few people were not even aware that there is a vaccine for KFD. It's difficult to connect the people living who usually refuse, especially with the 2 dose of vaccine. Most of them drop out for second dose of vaccine. So in that sense, we meant it synonymous here, ma'am.
Doctor, yes,
Ma'am.
because yeah, according to the dictionary, there's a subtle difference.
Yes.
You have told awareness, and later in the table you have mentioned as knowledge. And,
Yes, ma'am. For the purpose, we chose it as a synonymous, as you have rightly pointed.
yeah, and then when you told barriers in the training program, so it is felt barriers from the ASHAs, isn't it? The barriers of the program means from the ASHA side, isn't it?
Yes,
To
ma'am.
attend the program.
We took it from ASHAs. Yes, it's the felt barrier from the ASHAs what we took.
Okay, I felt that can be a little bit more specifically mentioned when you say barriers, because it's quite a wide, kind of vast terminology.
Yes, yes.
And,
Thanks for that correction, ma'am.
yeah, and when you're using 3D diagrams, I feel you should be a little careful because the 3D diagrams are different information altogether.
Okay, a 2D would be much better to repeat.
Yeah. Thank you anyway.
Yes, ma'am. I accept.
So, thank you for your time and thanks for your valuable feedback.
Thank you all for the wonderful presentations, and thank you for those two youngsters who coordinated this event beautifully.
Thank you, ma'am. Thank you so much.
Thank you and all the best to everybody. I thank the organizers, Team Ramaya, for giving us an opportunity to moderate this session. All the presentations were good. So it should not end here. It should lead to publications. That should be the end point. All the very best. Thank you.
Thank you, Dr. Renuka, ma'am. It was really nice.
Yeah,
With you.
Thank you, ma'am. Thank you. The next session 18 will be starting now.
Thanks a lot.
Thank you.
What happened?
Session 18 will start in 2 minutes.
Session 18.
A very good afternoon to everyone present here. Um, Good afternoon, everyone. I'm Chaitanya from 5th term.
And I'm Niharika from 5th term.
We welcome you to 32nd State Level Annual Conference of Karnataka Association of Community Health, hosted by Ramaya Medical College.
The theme this year is redefining public health, COVID-19 and beyond. So now, let us I'll introduce the judges, esteemed participants. We have with us today Dr. Jagdish Kodakar, Professor and Head of Goa Medical College, and Dr. Suma Nair, Professor and Head of Kasturba Medical College, Manipal. Now, I'm very, very thankful for the esteemed presence and the inputs which our judges are going to give us today. Thank you for your presence, sir and ma'am.
So we welcome participants. So the presenters, I'll just call once.
Please confirm if you are present.
Dr. Ramya,
Present.
Dr. Kavya?
Present.
Dr. Pavitra?
Present.
Yes,
I'm
present.
present.
Dr. Lakshmi?
Present.
Dr. Mauna? Dr. Mauna? Is Dr. Mauna here? She's there. So, yes. Audio, Dr. Mauna?
She's the last present.
Are we audible to everyone?
Yes, you are.
Is it clear?
Is it clear?
Yes, very clear.
Okay, thank you.
Just one thing. Hello.
Hello. Yes, ma'am.
Yeah, hi. Just want to tell you, I think Ramya, she's logged in two times. Maybe she could take away one because this could actually echo the whole thing. That's why probably there's an echo when you're talking. Just check. She's logged in twice, I think. Just.
Yes, ma'am.
Dr. Ramya, could you log out from one device?
Hello.
Yes, ma'am.
ಇದರಲ್ಲಿ ಲಾಗಿನ್ ಆಗಿಲ್ಲ
ಅದೇ ಓಪನ್ ಮಾಡಿ ಅವ್ರನ್ನೇ ರಿಮೂವ್ ಮಾಡಿ
You only remove one of it.
Okay. Okay, ma'am. So, I would now like to the Yeah. So the instructions for the presenters are, please make sure your camera and your microphone are functioning properly. Make sure you are seated in an isolated and closed space with proper lighting. Mute your microphones when you are not speaking. Minimize distractions from the background and avoid echo. Stay seated and be present. And the time frame will be 6 minutes per presenter, out of which after 5 minutes, we will give a reminder that you have 1 minute left. And followed by the 6 minutes, there will be a question and answer round by the esteemed judges. That will last for 2 minutes, and that will be your presentation with the question answers. So please stick to the given time frame. Your presentation will be stopped if you are exceeding the given time. Thank you.
So let's begin this session 18, which is oral presentation by faculty, topic being non-communicable diseases. So let's start the session with the first participant, Dr. Ramya V.
Yes.
Ma'am, should we present your PPT or will you present?
You can share your screen, ma'am.
You only share. Allow me to share. I have PPTs.
Yeah, allow me to share screen.
Should we allow you to share?
Allow me to share.
Okay.
Okay, ma'am.
Slideshow. Is it visible?
Yes, ma'am, it is visible. You can continue.
Okay. Let me present now.
Slideshow.
Yes, ma'am. Ma'am, your time starts now.
Put it on there.
Depression, anxiety, and stress level among the interns of Basaveshwara Medical College, Chitradurga. Introduction. Medical profession is one of the top profession courses chosen because of its esteemed place and financial security in the Indian society. Medical college is recognized as a stressful environment that often exerts a negative effect on the academic performance, physical health, and psychological well-being of the student. Objective of the study is to assess the depression, anxiety, and stress levels among the interns using depression, anxiety, and stress scale, and to compare the depression, anxiety, and stress levels among the interns. Coming to methodology, a cross-sectional study was conducted in the Basaveshwara Medical College and Hospital of Chitradurga. All the interns in medical college and who are willing to participate in the study were included. The depression, anxiety, and stress scale was used to assess the levels of depression, anxiety, and stress levels among interns. Coming to the results, among the 90 interns enrolled in the study, majority like 67 were in the age group of 23 to 24 years. 50 and 50 were males and 40 were females. The prevalence of depression, anxiety, and stress were found to be depression was among 90 students, 39 had depression, 57 had anxiety, and 90 students were suffering from stress. Most of the students were having mild degree of depression, anxiety, and stress levels. Coming to socio-demographic characteristics, among the 90 students, 22 were in the age 22 were age of 22 were 8, 23 years was 28 students, 24 years was 39 students, age 25 were 15 students. Coming to 50 were boys and 40 were girls. The native place among 90 students, 46 were from Karnataka and 44 are from out of Karnataka. Most like 50 students were staying in the hostel, 19 were living outside with the friends, 7 were living with the parents, and 14 were living outside alone. Coming to distribution of the study participant based on the stress levels, like out of 90 students, 39 were having depression, 17 had anxiety, 57 had anxiety, and 18 students had stress. Among each depression, mild depression was among 14 people, moderate also 14, like 35.9%, severe depression was 22.5%, very severe depression was only among 7.6% of the students. Anxiety, 17.5% students had mild anxiety, 54.39 has moderate anxiety, 12.28% of the students had severe anxiety, and 15.7 had very severe anxiety. Coming to stress levels, 50% had mild stress. Moderate 57.7 students had moderate stress, 5.5% had severe stress, and 16.67 has very severe stress. Conclusion, prevalence of mental health problems like depression, anxiety, and stress levels are among more than 30% among the interns. Majority of the students were having milder degrees of illness. They need to be addressed immediately before they manifest into severe forms. Coming to references. Thank you.
Thank you, ma'am. One request. Can you please switch on your video?
Yes.
And sir, ma'am, you can ask questions now.
Video. Wait. Video.
Hello.
Hello.
Sir, would you like to go first?
Okay, thank you.
Sir, you're on mute.
Okay, can I ask this question?
Yes.
Ramya is not visible, I think. Ma'am, we can't see her on the video, right?
Yes, sir. I'm trying to open the video. Show actors.
Doesn't matter. Can you answer this question? Once you did this study
Yes, sir.
and found
Yes,
significant
sir.
number of students with severe anxiety, depression, or stress, what did you do about it?
Yes, sir.
Did you refer them for counseling?
Till now, not.
Document that, or once you found that there were those with severe depression, anxiety, or did you do something about it for them?
I'll intervene, sir. Still now, I not intervened. I will try to intervene.
Because one of the reasons why we do a study is
Health
to do
education we have to give, and
they have to be, they require counseling, no, and psychosocial support.
yes,
Maybe
sir.
a psychologist.
Yes, sir.
Okay, over to you, ma'am.
Yeah, thank you, sir. Dr. Ramya, that was an interesting study, but I just wanted to know, like, how many interns did you approach? What was your
Only
total
90
sample?
interns. It has 100
90.
students. Yes, ma'am.
90, only 90 interns were there. All the 90 were part of your study.
Yes,
Is
yes,
that right?
ma'am.
Yeah. So almost all of them had morbidity as per your study. Everybody is having, you know, either depression or anxiety.
Not everybody,
Is
ma'am.
that how
Out
it
of
is? So you said 39%, 57%. So this is
no,
like
ma'am. Out of 90, 21. Out of those 21, how many had mild, moderate, severe? Table 2, madam.
no. You talk. Can you go back to that? Yeah.
Yes, ma'am.
So it is
Table 2.
39. That is out of 90, 39 had depression. Is that like that?
Yes, ma'am.
Then out of 90, 57 had anxiety.
Yes, ma'am.
And out of 90, 18 had stress.
Yes, ma'am.
So were they the same people who had, you know, multiple problem, or were they different people? Because if you look at this, there's 94 people who actually have a problem. So is it that out of 90, actually how many had a problem? All of them?
Not all of them had the problem, ma'am.
So how many had? Shouldn't you have done this among those who really had a problem only? Because this way, I'm not able to find out. It looks like I'm not able to get an idea as to how many of your interns actually had a psychological issue. If it is all 90, 100% having, then there's a serious issue.
No, ma'am. Out of that, only 13. We have to again, even some people suffering from depression may have the anxiety and also stress also.
Yeah, but that's not very clear. Like how many?
That scale includes combines all those things.
Yeah, I respect it. Yeah, otherwise, like Sir said, I think you may have to really think of some intervention, considering there is such a lot of problem, and probably you need to find out what really is causing this problem. I don't know. I just
okay.
Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Now, come to the presenter, Dr. Kavya.
Hello.
I think perhaps Dr. Ramya can mute herself because it's.
Yeah, now it's audible.
Dr. Kavya, will you present or should we present for you the PPT?
I will present one for you.
Okay, and then we can present.
PPT, share content.
ಇಲ್ಲಿ ಬಯಲು ಬಡ ಇಲ್ಲೇ ಮಾಡ್ರಿ ಇಲ್ಲೇ ಇರುತ್ತೆ ನೋಡ್ರಿ ಶೇರ್ It's not coming. Ask them to share. It's not coming. Can you share for me?
Okay, ma'am.
Screen.
Can you see your PPT?
Yeah.
Okay, ma'am. Ma'am, you can start.
Good afternoon. The study title is a study to assess the quality of life and factors affecting the quality of life of cancer patients admitted in KIMS Cancer Hospital, Hubli, a prospective study. Coming to the background, cancer constitutes about the 21.7% of. Next slide. Cancer constitutes about 21.7% of deaths due to non-communicable diseases worldwide, and cancer and many issues associated with it have significant impact on public health, and it is a disease with significant chances of reduction in quality of life. Thus, this study was done to assess the quality of life in cancer patients and to study the factors affecting the quality of life of cancer patients admitted in KIMS Cancer Hospital, Hubli. Next slide. Coming to the methodology, it is a study design is hospital-based prospective study. Study was conducted during the period of June 2017 to May 2018. The study population includes cancer patient admitted in KIMS Cancer Hospital, Hubballi. The cancer patients who were more than 18 years and diagnosed within past 2 years, and the patients who have received the chemotherapy or radiotherapy cycles less than 2 were included, and the seriously ill patients were excluded. Sampling method is purposive sampling method was used. The sample size included is 100. Next slide. Next slide. Then after obtaining the written informed consent, data was collected using a pre-designed and pre-tested semi-structured questionnaire, and the data was collected in 2 settings. One is at the time of the selection of the study participant and at the end of the 6 months. Quality of life was also assessed at baseline and at the 6 month of follow-up, and it is assessed using the questionnaire that is URTC quality of life questionnaire. Then after collecting the data was entered in Excel and analyzed using SPSS software. And for analysis, non-parametric tests like Mann-Whitney test, Kruskal-Wallis test, and Wilcoxon sign rank test were used. Next slide. Then coming to the results, table 1, figure 1, previous slide, previous slide. Slide number 5. Coming to the results, this is the figure showing the socio-demographic profile of the study participants. In the study, the 31% of the study participants belong to the 51 to 60 years age group, and only 3% include under the less than 30 years. And 57% of study participants were females and 85% were Hindus, and 73% of the study population were from rural area, and 60% were illiterates, and only 6% were employed, and the 52% of the study population belongs to the fourth class of socioeconomic status, and 72% were married. Next slide. Then this is the figure showing the distribution of study participant according to the type of the cancer and the stage of the cancer. In the study, 27% of the study participants belong to head and neck cancer, and 15% had gastrointestinal cancer, and 29% has genitourinary cancers, and 19% has breast cancer, and 4% has lung and bronchial cancer. And coming to the stage of cancer, 37% of the study participant were as stage 3 cancer, and 33% has stage 4 cancer, whereas only 5% were as stage 1 cancer. Next. Then this is the table showing the follow-up period, study participant at the end of the follow-up. At the end of the follow-up, in head and neck cancer patients, 33% were died, and 3 patients lost to follow-up. And in gastrointestinal cancer, 2 patients lost to follow-up and 6 were died. And in genitourinary cancer, 2% died, and in breast cancer, 2 were died. And total loss to follow-up was 7, and the death patients were 24. Next slide. Then coming to the next table, this table shows the quality of life at the baseline and at the end of the 6th month. Here we can see the quality of life here. It is divided as a role. One is global health scale, and according to the functioning, physical functioning, role, emotional functioning, cognitive functioning, and social functioning, and remaining all related to the symptoms of the cancers. In this, we can see here the quality of life is more at the follow-up period, and it is statistically significant with respect to global health scale and role functioning and emotional functioning and social functioning. And the symptoms like fatigue, nausea, vomiting, or pain, dyspnea, all has been increased at the end of the 6th month. Next. Then coming to the factors affecting the quality of life, the quality of life was good at the stage 1 with respect to global health, physical functioning, and whereas symptoms of fatigue and was highest at the stage 4 cancer. Coming to socio-demographic factors, occupational status had influence on physical and role functioning, which was good among the working group, and it is statistically significant. And educational status also had the influence on symptoms of insomnia, which is more among the illiterates, and socioeconomic status has influence on the cognitive functioning. And study findings also showed that the patient who had more financial difficulties have the low quality of life with respect to global health, emotional functioning, social functioning, and it is statistically significant. So the study concludes that the quality of life of patients under the study shows the significant improvement at the end of 6 months of follow-up after the chemotherapy. And the patients in advanced stage of cancer shows poor quality of life. And
left.
Then education, occupational and socio-economic status and economic burden has significant influence on the quality of life. The limitation includes quality of life here. It was assessed using the Likert scale. There might be chances of subjective variation, and we have not used the cancer-specific quality of life questionnaire. This questionnaire is a general questionnaire for all cancer patients. Next slide. These are the references.
Thank you, ma'am. Now I would request the judges to please put forward their questions.
Ma'am, Suma could ask the question first.
Yeah. Okay. Thank you, sir. Nice study, Dr. Kavya.
Thank you.
I just yeah. Any reason why you had a very large proportion of women in your study? Like it was a hospital-based study, but I thought almost 57% were women, right?
Yes, ma'am.
Any reason for that? I mean, just my
Because the type of the cancer, breast cancer and cervical cancer were more, ma'am.
the genitourinary included cervical cancer. Is that so?
Ma'am, genitourinary, most of them were having cervical cancer, ma'am. Okay. And breast cancer also more. That's why the population.
See, I just the thing. This quality of life would it have been better to assess after some time, because this is a very this quality of life I think pertains to immediate post treatment quality of life. Is that true?
After 6 months, it is improvement. Sorry, ma'am, I couldn't.
Okay. So do you expect it to further worsen, or would they all remain, better? I think that would be something which you can actually look at, because maybe an immediate post, and almost everybody had, improvement in their symptoms, including stage 4 cases, because everybody you said had all their symptoms improved over 6 months.
That thing we have not analyzed, ma'am. There are 23 patients has died now, ma'am. That could be a stage 4 cancer patients. They could be.
Thank you. That was interesting.
Thank you.
So over to you, sir.
Thank you, ma'am. Kavi, I wanted to ask you one thing. Your main
sir.
study objectives were about assessing the quality of life and the factors associated with quality of life. But looking at the diagrams, the graphs, whatever that you presented, much of it was devoted to the background characteristics, socio-demographic characteristics, other aspects. There was just one slide on the quality of life per se, which also included symptoms. And the factors affecting the quality of life were just summarized. Don't you think it was appropriate that there should have been tables or diagrams on those two things?
Yes, sir. Actually, the slide limits were 10. That's why
Yeah,
in
but
single slide I have included both baseline and follow-up and.
Much of the pictures were related to the other aspects, not to your primary objectives of study, right?
Yes, sir. Only one slide I have included, sir. Because it is like quality of life only. There are 13 components, sir. Like for each, it will take so many.
General quality of life scales to be adopted for this study, which is specifically on cancer. I think
This is
used
no, sir. This is with respect to cancer patients only. Again, there is a sub questionnaires for each type of cancer, sir. In URTC, like cervical cancer, there is a.
You did apply those, right?
No, sir, because there are so many types of cancer we have included and there are very less patients. If I want to take only cervical cancer, there were only 20 patients.
Okay.
Like if for breast cancer, that is for, we can't compare in that. Sample size become very low, sir.
Okay, thank you. Thank you, ma'am.
Thank you, sir.
Thank you. So let's call Dr. Pavitra.
Yes, am I audible?
Yes, ma'am.
Can you allow me to share my PPT?
Yes, ma'am.
Ma'am, you can start now.
Yes. Good evening. I'm Dr. Pavitra, Assistant Professor from Basveshwara Medical College, Chitradurga. My title of the study is A Study of Health Status of Bank Employees in Belgavi City. It is a cross-sectional study. So, since we know recent decades have witnessed tremendous advancements in health and survival throughout the world, due to economic transition and advancement in industrial revolution, the working pattern and lifestyle among workplaces has changed. Non-communicable diseases and occupation-related health problems have replaced communicable diseases. So this sedentary type of work pattern and mentally stressful job at bank has affected the lifestyle of the employees who are prone to risky behavior and are subject to risk of chronic diseases. So in a study, it was found that banks were among the top 10 high stress workplaces. So though the medical benefits are provided to this sector, there are no health promotion or preventive measures taken towards the occupational conditions. Hence, this occupational group of bank employees who represent the subset of population at risk to develop chronic diseases and stress-related health effects were selected to know their health status, the lifestyle factors, and the interventional measures were recommended towards their health promotion and prevention of occupational related morbidities. So objective of my study is to assess the health status of the employees and to know the socio-demographic and lifestyle factors affecting the health of bank employees. So it was a cross-sectional study. A list of nationalized banks were taken, and among them, the prevalence of diabetes, one risk factor was taken from the previous study. It was 21%. So based on that, our sample size was 410. So, and among them, around considering the employees in a bank, around 6 to 8 employees. So we had chosen around 60 banks, and the banks were chosen using simple random. So pre-tested, pre-structured and standardized questionnaire were used. They were interviewed and the data collection was done in person. So coming to the results. So in our study, around 79% were males and 21% females. And most of them were in the age group, that is 38% of them were in the age group 41 to 50 years. Coming to the other socio-demographic profile was taken. Coming to the lifestyle factors, so in around 60.73%, that's around 61% were having their sedentary lifestyle, and 39% were physically active. So seeing the association of physical activity and BMI, the prevalence of overweight and obesity was more among physically inactive study subjects, that is around 54% and 59% respectively. There was significant association. Coming to the prevalence of risk factors, the risk factors being sedentary habits, high fat and salt intake, inadequate fruits and vegetables consumption, smoking and alcohol, overweight, obesity. So around 5.1% had one risk factor. 21.5% of them had two risk factors, and 72.7% had more than three risk factors. The most common combination being overweight, obesity, and dietary habits. Coming to the investigations that had been done. So here we can see that the overall prevalence of anemia was 34.15%. Among males, it's 29%, and among female, the prevalence of anemia was 52%. The prevalence of diabetes, both known and newly detected diabetes, was 17% among the total study subjects. So this study concludes that majority of them were apparently healthy, but they were having multiple lifestyle and work-related risk factors. So what we would recommend is for them to incorporate inbuilt health program for the employees in alliance with health agencies, and to impart health education regarding risk factors and to adopt healthy lifestyle practices. Periodic screening for the risk factors and for the chronic diseases should be carried out regularly. Thank you. These are my references.
Thank you, ma'am. Now I would request the judges to please start the question and answer round.
Ma'am Suma, you could ask first.
Thank you, Dr. Pavitra.
Thank you, ma'am.
I just want to know, how did you sample, what was the sampling technique for those banks?
Ma'am, actually, I had taken one risk factor, that is the diabetes, from the previous study, the prevalence, that was 21.3%. And based on that, I have calculated by using the formula 4PQ by D square, the absolute error being 4.
That's a sample size.
Sampling day,
sampling. How did you
decide
which will be your...
Okay, so around there were 182 nationalized banks in Belgaum city. So the list was taken from the main branch. And then considering that around 6 to 8 employees were there in each bank, an average of 8 employees were taken in a bank. So to get a 410 samples banks, study population, so we needed 67 banks. So using simple random technique, we just chose the banks, ma'am.
Okay, and how did you decide people from the bank? Like who will be part of your study? Those who were present when you went?
Whoever accepted for this one, they were taken, ma'am. So the banks were reduced actually, because few banks there were around 10 or 15 participants. So whoever wanted to take part in the study were included in the study.
Okay, so basically it was purposive, right?
Yes, ma'am.
And how did you collect the diet data?
Diet data, it was, diet was, we were asking about the salt intake, mainly the risk factors, and the consumption of fruits and vegetables. That was taken, ma'am.
Okay, so there was no, it was not a food frequency questionnaire, 24-hour
No,
recall.
no. We're just
nothing like
asking about the salt intake, the fat intake, extra, normally how much it is an extra fat intake, and only the based on the fruits and vegetables consumption.
Thank you. So over
Thank
to
you,
you.
ma'am.
Thank you, ma'am. Pavitra, can I ask you something? This
Yes, sir.
study that you have done now is a cross-sectional study, right?
Yes, sir.
And it's done only in the banking employees, not in
Yes,
the.
sir.
Do you think, and plus you said you use the term risk factors. So do you think it is appropriate to use this term risk factors in a?
Yes, sir. Lifestyle related risk factor, because they are more sedentary. They have this 9 to 5 job and they are under stress. So they are more prone for these risk factors. They are not physically active.
Would you have preferred a different study design to study risk factors?
Like you wanted me to compare with the other.
No, I said you mentioned it's a cross-sectional study, right?
Yes, sir.
So if you had to study risk factors, would you have preferred a better study design? And may I ask you one thing, whether what presented, is it data from a larger study that you have done?
Sorry, sir?
Yeah, what you presented today, is it a part of a larger study that has been done?
Yes, sir. Actually, I've included occupational stress also in this. So I've divided it into only the risk factors here.
Okay, fine. Thank you.
Thank you, sir.
Thank you, ma'am. Now we would like to move on to the presenter, Dr. Lakshmi. Ma'am, are you there? Dr. Lakshmi? Ma'am, should we present?
No. Is the screen shared?
Yes, ma'am.
Yeah. Once.
Ma'am, you can start.
Good afternoon, everyone. The title of the study is Impact of Health Education on Knowledge regarding oral anti-diabetic drug adherence in urban area Bangalore. Diabetes, as we all know, it is a major public health problem. According to WHO, around 422 million people worldwide have diabetes, and majority are living in low and middle income countries. 1.6 million deaths are directly attributed to diabetes each year. In 2019, India has around 88 million diabetics, out of which 77 million are adults in age group of 20 to 79 years. By 2030, this figure is estimated to go up to 115 million. Diabetes can be treated and its consequences avoided or delayed with diet, physical activity, medication, and regular screening and treatment for complications. Diabetes patients require oral antidiabetic medication, either in single or combination therapy. There is a need to increase knowledge regarding diabetes, importance of drug adherence to prevent further morbidity and mortality, hence the present study was undertaken. The objectives of the study was to describe the socio-demographic profile in study subjects and to assess the effectiveness of health education or knowledge regarding oral antidiabetic drug adherence. The study was conducted in Urban Health Training Center. The study subjects were patients with type 2 diabetes mellitus, and the duration of study was a period of 6 months, and it was an international study with a sample size of 70, and the sampling method was pursuit sampling. Statistical analysis like percentages, mean, median, standard deviation, McNemer test, and paid pretest was computed. The inclusion criteria of the study population was patients with type 2 diabetes mellitus and only on adults, and the patients on oral antidiabetic drugs for more than or equal to 6 months, and patients willing to participate and giving consent. And the exclusion criteria was patients who were seriously ill. The subjects were administered a pre-tested semi-structured performer by interview method. The knowledge questions included a total of 11 questions on drug adherence. Health education was given using the audiovisual aids with minimum of 5 to 6 subjects in each session in local language. And the health education section included regarding the diabetes, drug adherence, and the importance of the drug adherence. And after 3 months, the same performer was used for post-test. Study subjects' knowledge was assessed with 0-1 scale for knowledge, with 0 as wrong knowledge and 1 for correct knowledge. And the mean age of the study participants was 52 years and the standard deviation 11 years. And the median was 51 and the interquartile range 50. Majority of the study participants were females and they were Muslim by religion. And regarding the education of the study participants, around 31% were educated up to middle school and 40% were illiterate. And majority of the study subjects were unemployed, that is 67%. And this is a table showing the correct response of study subjects regarding knowledge on oral antidiabetic drugs before and after health education intervention. And it was analyzed using McNemer test. And these were the questions asked. And there was this significance. A total of 11 questions were asked and 0 was computed for the wrong answer and 1 for the correct answer. And this is a graph showing the normal QQ plot of difference between post-test and pre-test knowledge score regarding oral antidiabetic drugs. And in this graph, it is observed that from the above normal QQ plot that the difference between post-test and pre-test knowledge scores are normally distributed, and hence students' paid t-test is used for testing the significance difference between the mean of pre-test and post-test scores. And this is a table showing the comparison of pre and post-test knowledge score among the study subjects about oral antidiabetic drugs. And in the graph, for the pre-test assessment, the mean or plus or minus standard deviation of knowledge was 4.64 and plus or minus 2.04. And for the post-test, it was 10.06 plus or minus 1.44. The difference in the mean was 5.41 with a 95% confidence interval of 4.89 to 5.93 was found to be statistically highly significant. And this implies that there was improvement in knowledge following health education in study subjects. And to conclude, the study revealed that there was significant improvement in knowledge after health education. And the recommendation is health education has to be given to encourage and motivate the patients for the management of diabetes and to prevent complications. These are the references. Thank you.
Thank you, ma'am. Judges can please vote that question.
Dr. Lakshmi, well presented.
Yes, sir.
So just one thing. when you're presenting the objectives of study, no, do
Yes,
you
sir.
think the first objective that you presented about
Yes, sir.
socio-demographic profile of study participants, would that be an appropriate objective of the study, or it is something that we do routinely in any study?
And depending, we should know basically the baseline, like what is the education answer, so it is important, sir.
Yeah, but would you like to enumerate it as an objective of a study? You don't do a study to just look at the socio-demographic profile, right? It is something we do it in every study.
Yes, sir.
Explain the baseline characteristics.
Yes, sir.
But well presented. Ma'am, your question, please.
Yes. Yeah, nice study and well presented too. I just have a couple of questions.
Yes, ma'am.
Yeah. Was the duration of diabetes a criteria for including the participants in your study?
It is more than more than or equal to 6 months duration.
No. The patients with diabetes more than equal to 6 months.
Yes, ma'am. Overall,
So suppose we had it for over 15 years.
Yeah, ma'am, it is included, but there should be an oral anti-diabetic drugs for more than or equal to 6 months. We have only taken the drugs adherence.
No, but I just wanted, because do you think there could be a difference when the more longer you have a disease,
Yes,
oral diabetic drugs may not be the only agent, or maybe they may not be the primary agents of treatment. So I think there could be a difference. So that I did not see the difference here. And how soon were they evaluated after you implemented this health education?
Ma'am, sorry.
How soon were they evaluated for the post-test?
For the post-test, after a period of 3 months, and the health education was given with a minimum of 5 to 6 participants after the pre-test month.
Okay. Your outcome was to see whether they improve better on the theoretical knowledge, right? You just
Yes,
wanted to
ma'am.
see. Yeah.
Yes,
But do you
ma'am,
think that could have been done in a different way? Because after all, this is diabetic education, right? So maybe something else could have, to say that they knew, they could have just by hearted and maybe they just knew and put all those tick marks. But giving a health education, probably your outcome could have been a behavioral change in some way. I mean, maybe you could have evaluated the diabetic status or glucose control.
Yes, ma'am, I could have done, ma'am.
Yeah, I think that would have been a better outcome than just saying that so many people answered correct, so many did not answer correctly. That's a very theoretical look at, like a recall based thing. So that was a very valid study. Thank you.
Yes, ma'am. Thank you.
Thank you, ma'am. So now let's move on to next participant, Dr. Mauna.
Yes, can you hear me? Yeah, this is Dr. Mona. Please allow me to share the PPT.
Should we share the PPT or should we allow you to share the presentation?
Allow me to share.
Okay, ma'am.
I'll present. Okay, thank you. Thank you. Very good. Shall I start?
Yes, ma'am, you can start now.
Okay, thank you. A very good afternoon. Today I shall be presenting a title with the study, a study to assess pharmacological accessible adherence among the hypertension patients residing in the urban field practice area of the Government Medical College. Moving with the background, hypertension is a silent and asymptomatic disease. If not controlled, can lead to fatal complications such as stroke and premature morbidity and mortality. But hypertension is a treatable condition and can be controlled with good adherence to antihypertensive treatment. But nevertheless, lifestyle modifications will also play an important role. And since the treatment is lifelong and the adherence is affected by multidimensional factors, which poses a tough challenge, especially among the urban slum population, And a community-based study like this can help us to assess the extent of adherence, extent of adherence to the antihypertensive medication. And the primary objective of this study is to assess the pharmacological adherence to the antihypertensive medication among the hypertensive patients. And the second objective is to study the clinical profile of the hypertension patients residing in the above field practice area of the Government Medical College. And it's a cross-sectional study done in the urban slums of field practice area of Department of Community Medicine in Bangalore. And the study population included the hypertensive patients who were aged more than 18 years and above and who are on medication for more than 6 months, and the individuals who are ready to give the consent, and those who are diagnosed with major psychiatric illness, and pregnant and lactating women were excluded from the study. And the study period is between November 2017 to May 2019. And the sample size was calculated based on a study conducted by Baburao et al., where the adherence was found to be 60.6%, and using formula 4 pq by d square, a sample size of 382 was arrived, and which was rounded off to 390 later. And the sampling method here used is the probability proportionate sampling method. And the data was collected by interview method using semi-structured questionnaire, which included the socio-demographic factors, hypertension-related details, and adherence to hypertension medication. And this data was compiled and analyzed using the SPSS version 2020 using appropriate statistical tests. And moving with the results, first section, that is the socio-demographic distribution. Around 46% were from the age group of 46 to 55 years, and around 58% were female by gender, and around 68% were Hindu by religion. And based on the education level, around 37.7% hadn't done their schooling, and around 30.8% were semi-skilled workers by their occupation. Majority were from nuclear family, that is around 56%. And based on the socioeconomic classification, that is the modified Kuppuswamy classification updated as on 2017, around 45% were belonging to the upper lower class, that is class 4. And adherence to the distribution of the adherence to the antihypertensive medication among the participants, where a pill count method was used, which is a self-reporting method. And it was calculated by using number of tablets consumed by total number of tablets prescribed into 100. And if it is more than 80%, then it was considered to be adherent. And if it was less than 80%, the patients were considered to be non-adherent. And this is the figure showing the adherence, wherein around 63% had a adherence rate of more than 80%. And this table shows the association between the adherence to the antihypertensive treatment and the controlled blood pressure status of the participants. That is around 64% had controlled blood pressure status, and there was a statistical significant association between the two factors. And this table shows the distribution of the clinical profile of the participants. And based upon the duration of the diagnosis of the hypertension, that is between 6 to 11 months and 12 to 60 months and more than 60 months, all had a equal distribution here. And around 56% of the participants were prescribed 1 pill per day. And coming to the family history, around 18% had a positive family history, and around 44% had a comorbidity, of which diabetes was the most common, and around 70% were seeking treatment from the government facility. So to conclude with, in this community-based study, the mean age of the participants is found to be 50.43 years with a mean standard deviation of 8 years, and more than half were literates, and majority were employed, and around 30% were semi-skilled workers, and around 18% had a family history positive, and adherence to the antihypertensive treatment was found to be 63%. And in this study, the controlled BP status was found to be 64%, which has statistically significant association with the adherence. And the limitation of the study is it's a pill count method, which is a self-reported method for the past 1 week, which might have a recall bias. And since the population is around 390, which cannot be generalized over a large population, so it has to be done over a large scale. Okay, this ends my presentation. Thank you.
Thank you, ma'am. Now I would request the judges to please put forward their questions.
Ma'am, may I ask first?
Yes, sir, please.
Yeah, thank you, ma'am. Mona, very well presented, huh? But can I ask you two
Thank you,
things?
sir.
Were
Yes,
you
sir. Yes,
studying
sir.
adherence or non-adherence?
Sir?
Were you studying adherence to the interventions or non-adherence?
Adherence, sir.
Adherence. So apart from this method that you employed, pill count method, are there any better methods which you could have considered to do the study of adherence?
So
If you
there
had
are other
done
scales also, but I prefer this. There is Morisky MMS 8 scale, Morisky, and there is a drug attitude inventory scale. And there is a clinician rating scale. There were many, but since the Morisky had a issue with using this, there was rights were not given. That's why I used this, sir.
Okay, no problem. Thank you. Ma'am, your question, please.
Thank you. Dr. Mona, it was a brilliant presentation, and I think the study was really nice, very well conducted, and your methodology was really good. It was all to a T. And anything like Sir said, probably you could have used some other type to assess adherence, but well done. I just wanted to know, was the adherence, associated with duration of the blood pressure? I think you
Duration.
did look at it, but I wasn't sure because you quickly ran through your slides. I couldn't really look at it clearly. But is there any association between duration of having the disease and adherence to the treatment?
Yes, ma'am, I did see that, but there was no associations in.
Okay. So whether they had it longer duration or lesser adherence was not an issue. I mean, it was the same, was it?
Yes, ma'am. Yes, ma'am.
And the control, the BP control, was it associated? Again, I think I saw one slide, but I really didn't. Can you just show that, your slide? I'm not sure. The previous or the one before that? Control of blood pressure and adherence association.
Sorry, ma'am, I couldn't hear.
The control of blood pressure, was it
Yes, ma'am.
associated with the adherence to treatment?
Yes, ma'am, it was associated.
Yeah, can you show me that slide, please? Wherein you showed that. I thought there was one slide which showed that. I'm not too sure. I could. Can you go back to the slide?
Ma'am, they should allow me to share the. I think I have stopped it.
Oh, okay, they stopped it. Don't stop it till the.
Ma'am, we haven't stopped it. Maybe you should just try it.
Try again, ma'am.
Okay. Yes, ma'am, this slide, ma'am.
Yeah. So, so if they had more than 80% adherence, control. Okay. Not much of a
It is
difference.
divided
Right?
as like controlled and uncontrolled, and based on the adherence also.
How did you define controlled and uncontrolled?
Ma'am, I had checked the BP, ma'am. I manually I had checked the BP. So based on that, I had categorized that controlled and uncontrolled, ma'am.
Okay, because they are all known hypertensive. So did you have a
Yes, ma'am,
cutoff point to say they were controlled?
Yes, ma'am, I had, ma'am. I followed JNC 8 guidelines, ma'am.
Because control may differ based on what age they are and what kind of other comorbidities they have, etc., etc. Okay, so
According to JNC guidelines, it is like normal is 120 by 80, and pre-hypertension is 120 to 140 by 90, and stage 1 is more than 140, and stage 2 is more than 160, ma'am. So that is how it was categorized. So based on the hypertension which I noticed, I classified them whether it was controlled or not, and and it is the, and also I asked for the adherence also, ma'am, like what was their pill count in the previous week.
Okay, yeah. No, that's what you have. The classification is probably by the diagnosis stage. But when you're looking at controlled, probably you can actually have a definition which is probably more in keeping with the kind of, disease that they have, I mean, comorbidities that they have along with this and so on and so forth. Just a thought, maybe you can just look at that. So you will have a better idea because it's not that everybody has to have 110, 80. It may not be recommended also, so.
Yes, ma'am.
But otherwise, yeah, very nice. Well done study. Thank you.
Thank you. Thank you.
With this, we end this session. I would like to thank all the presenters for their wonderful sessions and their presentations. Also, I would like to specially thank the judges who were very interesting and their knowledge shared has helped all of us. And thank you for enlightening us, sir. Thank you, ma'am.
Thank you.
Thank
Thank you,
you.
Dr. Chitra.
We will now end the session. Thank you for everyone for joining in.